Welcome to the Crisis Academy Children's Crisis Response. My name is Alicia Clark, and I am the Assistant Director of Community Planning and Collaboration for the Ohio Department of Mental Health and Addiction Services, and I'm welcoming you on behalf of our Director, Director Lori Chris. The state of Ohio is transforming children's behavioral health at this time, and we're working together as partners to support the continuum. We're looking at prevention promotion, and of course, crisis services. We're working across the children's behavioral health system at this, because this is a priority of Governor DeWine, and he has made this one of his top priorities. Ohio's vision for crisis services is for every Ohioan, including young people, to have access to a visible and accessible system of services and supports that are person-centered, quality-driven, and focused on ensuring young people are stabilized and thriving in their own homes and communities. Ohio is transforming this approach to children and youth behavioral health services with a comprehensive response system for families who require support from multiple state systems. Those families, we're working so that we can achieve a widespread and sustainable system of care. Ohio's crisis continuum for children and families is to intercede before urgent behavioral health situations become unmanageable and emergencies for families and caregivers become emergencies for families and caregivers. I apologize. This is a great time for Ohio to look at children's crisis services and supports, and we are excited to have Elizabeth Manley, Marisa Weisel, and Mike Kenney represent residential interventions for youth. Thank you for joining again. And next you'll hear from the Executive Director of the Ohio Association of County Behavioral Health Authorities, Sherry Walters.
Good morning. Welcome to Ohio's Crisis Academy on Children Crisis Response. I am Sherry Walter, and I'm going to give you a few housekeeping items that we want to go over. I also want to take just a minute and thank the Ohio Department of Mental Health and Addiction Services. It is their support that allows these crisis academies to occur, and we're very appreciative of that. I also want to very much thank Michaela Radish. She has been planning kind of from the get-go for the entire Crisis Academy. I also want to thank our planning committee that included both board directors, folks from provider agencies, and other stakeholders who wanted to make sure that you had a really good opportunity to learn today. So a couple of housekeeping things. We are using the Zoom webinar, which means that attendees can't use your microphone or your video, and we will not be able to see or hear you. The chat function today is also disabled. While the panelists and I can send you information through the chat, you won't be able to respond. If you do have a question that pops up as you are listening to the presentation, feel free to add to that question to the Q&A box. We have folks who will be monitoring questions throughout the training, and at the end, as long as we have enough time, we will pose some of these questions for our presenter. They will also be answering questions on the go through the chat box. So you may want to, or through the question and answer. So you want to spend some time keeping an eye on that. And if you could please keep your questions related to the context and topics we are talking about today. If you do have any kind of technical difficulties throughout this training, please contact Michaela Radish. You will have her information. That's who you signed up with. She will also be posting her email in the chat box for your convenience. If you would like continuing education credits, this training has been approved for 2.75 CEs for nurses, social workers, mental health counselors, prevention professionals, chemical dependency counselors, and psychologists. By logging in today, we have your attendance, and we'll be able to see how long you have participated in the training. If you log out early, we will adjust your certificate to the amount in which you participated. And please note that we're unable to verify attendance for any of you that may be joining the webinar by phone. Following today's training, Michaela will send an email that includes a SurveyMonkey link. This will allow you to evaluate the training, and you must complete this evaluation within 1 week after the training in order to receive your CE credits. Please ensure that you provide your license number in this evaluation. And after completing your evaluation through SurveyMonkey, your certificate of attendance should be emailed to you within 2 weeks. Today's training is also sponsored by the Great Lakes Mental Health Technology Transfer Center. We'd appreciate your completion of the GIPRA assessment, which will also be included in the email that you received from Michaela. Now I would like to introduce our speakers. Our primary speaker is Elizabeth Manley. She serves as the clinical instructor for health and behavioral health policy at the University of Maryland's Institute for Innovation and Implementation. In this capacity, Ms. Manley provides technical assistance to states and communities specific to children's behavioral health innovations with a specific focus on policy, financing, and development of service array within a system of care. Ms. Manley is the former Assistant Commissioner for New Jersey's Children's System of Care. In this capacity, Ms. Manley led transformation and implementation of system innovations, including integrating individuals with developmental and intellectual disabilities, substance use, and the integration of physical health into the children's system of care. Ms. Manley also has extensive care management experience, having served as the CEO of Caring Partners of Moore Sussex, Inc., and the Director of Operations for Capital County Children's Collaborative. Ms. Manley will be joined today by Mike Kenney. He's the Director of Strategic Initiatives from the Children's Public Services Association of Ohio. We will also have Marisa Weisel, Deputy Director of Strategic Initiatives, and Kelly Smith, Ohio Rise External Affairs Administrator with the Ohio Department of Medicaid. They will be talking about the work Ohio is undertaking with Ohio Rise and other children's crisis issues. So we hope you really enjoy today's Crisis Academy. We have a great lineup of speakers. So with that, I'm going to hand it off to Ms. Manley. Elizabeth, thank you.
Thank you. And thank you for having me today. I'm so excited to join you. And I know that this is an interesting topic, residential interventions within systems of care. But I think it's an important one. And we're going to work really hard today to connect the dots around all of your current transformation and how it fits. Because all of the transformation that you're doing and all the work that's happening around Ohio Rise is so important in improving residential interventions for young people. So let me just again say, I'm happy to be here. I do work for the Institute for Innovation, and I've been working around the country mostly on two really important topics these days, and that is mobile response and stabilization, which all of you are getting ready to experience and I know are doing a lot of work on, and residential interventions. And sometimes people ask me how these two things come together. So let's get talking about that. One other thing before I start, and that is in my resume, you heard a lot about the systems work around care coordination and around crisis systems. But what you didn't hear is that I also worked and ran residential programs in New Jersey for 15 years before the children's system of care started. And one other thing that you don't know, but I'm happy to share with you today, is when I became the Assistant Commissioner for New Jersey's Children's System of Care, what I didn't do was to go to, at least it wasn't initially my intention to go to this work for the state so that I could fix residential. And when I got there, I recognized how much work really needed to be done in order to ensure that young people get what they need at the time they need it for the duration. So today I'm going to work to connect the dots. I'm happy to take questions as we go along. I'm going to hit on a lot of different topics, and we're going to start, I think, by really getting to what's the heart of this work. The heart of this work is that what works best is anything that increases the quality and number of relationships in a child's life, and that it's people, not programs, that change people. And if we remember that and remember that work, then really the work of systems transformation is about putting skilled and qualified people in the lives of children at the time they need it, really hitting the points in which young people and their families are struggling most. And this quote is by Dr. Bruce Perry, who's, I'm sure most of you are very familiar with his work. Certainly his new work out on what happened to you is just really important work for us to understand. And some of the basis of how systems transformation is really designed and organized is about the sequencing of when and how interventions are put into place to ensure that that we're getting the maximum output from them. So we'll talk a little bit about that today too. Like I said, I take questions as we go. So, but let's start at the beginning. You're talking about major systems transformation that's happening currently in Ohio, and very exciting things. Mobile response and stabilization. Let me just throw some acronyms at you. Right, you have now a COE, you have MRSS, you're working on CMEs, PRTFs, QRTPs, and CANs, all new alphabet soup. Today, we're going to talk about the importance of that alphabet soup in really transforming the lives of children and families. And so I'm going to translate all of those words for you. And that's the last time I promised today that I will use acronyms. So we start with the Center for Excellence and what its job is, and trying to make sure that folks, that you have skilled workforce across your full state, providing the tools necessary to provide those really quality interventions for young people. You have mobile response and stabilization, which we'll talk later about, meeting the sense of urgency for families, so important in systems design. CME, or care management entities, are important in ensuring care coordination is happening. PRTF, which we'll talk quite a lot about today, which is the Psychiatric Residential Treatment Facility, the QRTP, the Quality Residential Treatment Programs, and the CANs, the Child and Adolescent Needs and Strengths Tool. And all of these things come together. So when we talk about systems transformation, we really are talking about how things integrate and how they come together. But let's start by talking about policy. It's such a fun topic to talk about on Friday morning, but really important because policy drives practice, right? And sometimes we need to make sure that not sometimes, always, we need to make sure that those policies are really aimed at meeting the best interests of children and families. And sometimes we get sidetracked on silos. We get sidetracked on funding streams. We get siloed on other things. What we want to focus on in the policy decision-making is, are we serving the right population with the right resources, ensuring that the right financing tools are in place, and that regulations and rates all match. Okay, so really important that we pay attention to policy and management. We want to pay attention to the data and the data collection and the quality, continuous quality improvement strategies that are built into all of this work. And that how the system is organized is important. Who's doing what at what time in the sequencing for interventions for young people and their families. And that population and accountability is part of this work. That practice, right? So transformation doesn't just happen from a state policy perspective. It also happens from workforce development, developing assessments that make sense, making sure that the workforce has the tools that it needs, ensuring that there is good care management, and that care management is monitored and paid attention to. That we have community partnerships. And I talk a lot about the importance of community engagement strategies, because a lot of young people who have behavioral health needs really first need to have really connections to their community supports before even formal interventions happen or go into place. And so it's important for us to really pay attention to these ideas of community engagement and community engagement strategies. Let's talk about silos, because silos are incredibly important, and part of the challenge in systems transformation is to get people to begin to think differently about their work, right? So the work that Marisa and Kelly are doing at Medicaid, right, is important work. And one of the real powers of this team is that they're not just thinking about the work of Medicaid, right, and the payer. They're really thinking about quality interventions for young people, how to include the community in those conversations, and how to really think about the design of all of this work, right? How do you design psychiatric residential treatment programs that are going to really help to meet the needs of young people? But then how do you build in intensive care coordination and mobile response? This is not easy work. It's really complicated and difficult work. But one of the things it is allowing Ohio to begin to do is to think outside of the silos of the way that we organize and think about work. That's the first part of the work of systems transformation, is for us to all agree that what is in the best interest of children and families is the vision. Right? We don't lose sight of that vision of making sure that children get what they need at the time that they need it, for the duration that they need it. And we're going to worry about how to pay for it. We're going to worry about, some of the other concerns about who's going to do the work, how those providers are going to get paid. All of those things are important. But the most important thing, I think we can all agree, is that what children and families need is what we want to ensure that they get. So in order to do that, we have to begin to think about life outside of these silos. And when I talk about the silos, I'm talking about education silo, child welfare, juvenile justice, mental health, intellectual developmental disabilities, substance use. I'm talking about, the silos of payers, Medicaid, private insurers, all of the payers that come to the table as well. And whether or not you work in a hospital-based system, a community-based system, whether you work providing intensive care coordination or outpatient care, whether you're doing assessments, wherever it is you sit in this work, it's time to begin to think about the work differently. And when we talk about children in residential care, this is incredibly important and sometimes misunderstood dramatically. We think residential sort of sits over here and children are going to go to residential and then they're going to come back. And I'll tell you a quick story. So I think it sort of tells our story of growth and development in New Jersey for sure, is that when I first started and working in one of the more rural parts of New Jersey, providing high fidelity wraparound, I had a group of people from that particular county tell me that the way they viewed the system was that the contracted systems administrator at the time would go into the county, pick up children, take them to residential care, and send them back in worse shape than they were before they went. And this is not the way that we think about systems reorganization, but that's the way that it felt for folks prior to the organization of the system of care and how it was organized. And what we wanted folks to begin to feel is their importance at the table when children are in a residential intervention right from the start. And so it's important for us to begin to think about our work outside of these silos. Really important for us to begin to think about that. And the way that we do that is begin to talk to each other. Right? We have to talk to each other on a regular basis about lots of things. And we have to begin to use more common language in our conversations. One of the big lessons that I learned in New Jersey, and you know what, let me step back for a second and just talk a little bit about New Jersey's transformation, because I think it's helpful to see an illustration of what I mean. New Jersey's, I've been on the ground in New Jersey, or was on the ground in New Jersey for a very long time. I worked in residential care, mostly running the first, New Jersey's first attempt at psychiatric residential treatment interventions for children back in the 90s. And these were small residential treatment programs whose focus was on keeping young people in their own homes and communities who were coming out of inpatient care. And the goal was to keep them out of the state hospital. We were pretty successful, started to work around, good work, but we had none of the other features of systems reform that we'll talk about in a second. And then in 2000, the year 2000, there was a concept paper published that said, this is our vision for our children in the future. Our vision is to keep them in their homes, in their schools, in the communities by providing the right service at the right time for the right duration. And we're not doing a very good job now because we know we're not doing a good job right now because look at our data. Here's our data. Most of our children are out of state residential care. We are overcrowding in all juvenile detention centers and building bigger ones. We have crowding in all of our local inpatient units, emergency departments, and our state hospital. And our parents have to touch on child welfare in order for them to get what they need, in order for them to get any kind of behavioral service. So that's where we started this work. We started with one of the worst child welfare systems in the country. Arguably, we now have one of the best child welfare systems in the country, keep most of our children in their own homes, and can do the work that's necessary to take care of children around protection and permanency, which is so important. We have closed 9 detention centers here in New Jersey and 1 prison, getting ready to close another detention center any day now. Have also reduced the daily population in residential, brought all of our young people back from out-of-state residential care, and did a lot of quality work on residential to ensure young people get the time they needed, but also around restraint, seclusion, and coercion, which we'll talk about today. So a lot of work has been done. Closed the only state hospital, have the lowest rate of children in foster care on psychiatric medication, one of the lowest suicide rates in the country. And have one of the best education systems in the country. Now, all of those kind of reforms take place in their own silos. There's no doubt, education-focused work, juvenile justice-focused work. But if you don't meet the behavioral health needs for children in a way that makes sense and is organized, that it takes away the worries and the funding issues and the challenges for families, then all of the impact is in all of those other systems, right? So important for us to recognize how all of these things come together. And this issue of communication is not insignificant in terms of the work. And in some ways, it's low-hanging fruit because it requires us, all the professionals and the folks who are important in children's lives, to come together and talk to each other, right? So that's what's really important for us to think about and to do. So we want to come together, we want to talk to each other, we want to use language that is consistent across the board. Because language matters. And anyone who's done this work recognize the real importance in systems transformation starts with how we talk about children, youth, and young adults, how we talk about families, how we talk about the work itself, all begins our transformation. That's how we begin to transform. And language is so important that I always put a language slide in all of my conversations with every state that I work with. And put it in perspective, I've worked with about 25 to 30 states on any given time around lots of different topics and of interest. This is a particularly important one, I think. So when we talk about the transformation of language, these are the things to begin to think about. How we think about children is important. Children, youth, and young adults is the language that we want to use, not clients, not cases, not consumers. These are not words that are helpful in the world of children. And it's really important that we begin to move away from this language when we're trying to level the table and have parent and children sit at our table to be part of the decision-making process. So as we think about that, right, we want to talk about parents and caregivers, not mom and dad. It's not my mom and dad. So I don't get to talk about parents from that perspective. And when we talk about the shifting in language, I'm talking about shifting language in all policy, practice, in records, right, in the electronic health records. It's not easy work, but it's important work for us to stay focused on children, youth, and young adults. We talk about parents and caregivers. We want to talk about treatment and treatment interventions. And this is a really important part because sometimes we get really focused on where that child's going to put their head on the pillow at night. And we forget about what the interventions are and how those interventions are going to play out, not just in the short term, but in the long term for young people. In other words, if we don't get the right treatment intervention into place, and we use a residential intervention for a young person who is not ready, it's not sequenced right, it's not the right support to go in place, we haven't prepped them, we are not using trauma-informed care, we have the potential to do much more damage to those young people, not just in the short term, but over the course of their lifetime. And these decisions are really important for us to pay attention to. So when we think about what happens for young people, we want to separate the conversation of where they're going to put their head on a pillow and whether a treatment intervention is necessary. We can certainly talk more about that as we go through today. We want to talk about engagement. It is the responsibility of adults to engage young people. I have never had the expectation that any young person that I've ever touched on would come into that conversation engaged and ready to go, in particular when they're touching on the behavioral health system. The job is about engagement and helping young people see why it's important that we're going to be in their lives. And this is a slow, methodical process of engagement that requires us to be persistent and consistent in our language and to work with all of the other adults in that young person's life. Engagement is essential if we want to get to transformation. I used to tell the folks in New Jersey when I was assistant commissioner that, hey, if I see not motivated in your record, then we're going to come back and do some training. And I read records on a pretty regular basis and really got to see as the workforce shifted their language away from this idea of not being motivated. It is not the job of young people to be motivated. It is our job to motivate them. And it is our job to come to the table with the skills necessary to be motivated. This is why you need a Center for Excellence to begin to do this type of work. We also need, we need to recognize the power of words like transition. And when we talk about transition, when we're talking about children, we are talking about the professionals stepping back. We are not talking about families leaving us. We are going to step back, because if our frame is that we are going to actually support young people in their own homes, then the job of the professionals is to step back from those homes. So we don't close, we don't terminate. Just terminating 13-year-olds just seems really harsh and overwhelming. So we want to talk about missing and runaway children. This was not on my radar until when I was at the Department of Children and Families in New Jersey, and Superstorm Sandy hit. And the federal government, our federal partners came in and were prepping us for what we really needed to focus time and attention on to ensure the youth and families in New Jersey got what they needed. And so this team from the federal government came in and they said, you have to worry about three things, right? You really need to worry about an increase of in concern around abuse and neglect. You need to worry about an increase in domestic violence, and you have to worry about an increase in human trafficking. First two, we were not surprised about. The third, we said, whoa, wait a minute, what does that mean? And we recognized that as we got trained and as we trained the workforce around this issue of human trafficking, that young people who were at highest risk were almost all part of either the child welfare system, the juvenile justice system, or the behavioral health system. And we wanted to really focus time and attention and recognize that for our young folks who are not where we think that they should be, right? They're not where they're scheduled to be. Then our job is to go find them, bring them back, and ask them why they were missing in the first place. And then if we moved away from language like running away, we could galvanize law enforcement to help us. We could galvanize communities to help us find these young people, bring them back, find out why they were missing in the first place. And if we did that type of work, we were also communicating to our young people that we cared about them. We cared about what happened to them. We cared about what was important to them. And we could really help prevent some human trafficking work. So this has been part of our language now for almost 10 years and has made a big difference, I think, in young people's feeling about the system being supportive of them over the long term. Not perfect, but it works so much better for us to galvanize adults, to get them at the table to say, hey, what's going on? How can we help you? And how can we be more supportive of you? It also gets back to that engagement strategy, right? We want to engage young people. And then as we talk about residential interventions, it's incredibly important for us to move away from language like home visits. Children don't visit their homes if we want them to be part and continue to be part of families. They have family time. They spend time with their family, as much time as possible in a residential intervention as we can put together, which is really part of the new work as we move forward. So we do have a comment in the chat, which I think is interesting and important. Yes, we move away from language like compliant, and I'm going to talk about compliance. So yes, we're definitely going to do that for sure. Because compliance isn't helpful in the world of children's behavioral health. In fact, it can be counterproductive to have young people who are compliant. Okay, so in order for us to talk about, and you'll hear me talk about residential interventions, I'm going to get to what a psychiatric residential treatment facility is, and I'm going to talk about a QRTP, or qualified residential treatment program in a minute. But for me, it's important to recognize that residential interventions, places in which young people go outside of their family, outside of their communities, and reside for treatment interventions, that those are residential interventions, and they require us to be really attentive to what happens in those programs, okay? And some of the ways that we're going to do that are laid out in the Building of a System Care Primer that was authored by Sheila Pyries. where she talks about moving away from placement orientation and long lengths of stay, right? So when you hear people talk about this young person needs a long-term residential program, my question is, what does that mean? What does long-term mean? And why are we using the language long-term? We definitely want to move away from that. Residential as part of an integrated continuum and connected to the community is really important, and it is best practice. And we'll talk a little bit more about that, what that best practice looks like. There's shared decision-making, right? And that shared decision-making means that the residential intervention, right? The residential partner is one partner at the table, right? And that we have other partners at that table who are going to help figure out what is the best plan moving forward. That young people have a voice at that table. Parents have a voice at that table. So do the residential partner. And hopefully we have some community partners who are going to be part of this conversation as well. That we're doing an individualized treatment approach. In other words, we're going to sort of pick from a menu of what young people will benefit from within the intervention itself, so that it's not a cookie cutter schedule. It's not a cookie cutter intervention. Some young people actually respond differently to individual therapy, as an example. Some embrace it and think it's one of the best things they could ever get. And some young people, it's not where they're going to learn, grow, and actually do well. So we need the ability within a treatment continuum to be able to organize in a way that makes sense for young people. And that requires lots of time and attention to what's going to happen for young people. That all needs to be trauma informed. In fact, we want to get to a place in which there's universal understanding of trauma informed care, but also that every residential intervention that you provide is providing trauma informed care as the basic of the first step of what they do. This is the baseline is trauma informed care, and then we move from there. And this is all part of the Building Bridges initiative, by the way, for folks who are not familiar. There's some really good work that's happening at Building Bridges. But when we talk about transformation, we're talking about at the organization level, the systems level, and the practice level. And today, as we talk about residential interventions, we want to talk about all of these things. We want to talk about how shifting the way that we think about children, using the language that we think about children, all of that becomes incredibly important within this discussion. And that there's a nimbleness within this work that allows us to shift gears as we learn important lessons in practice-based evidence, that allows us to shift gears to say, you know what, we need to do something different and more, whatever it is, right? Talk a little bit about that. I want to talk about leadership real quick. And that is that leadership, in my view, comes not just from the state level, and you clearly have leadership at the state level who's working really hard to transform systems for children and families, and doing incredible work in trying to organize the system in a way that will make sense for children and families. But leadership is also at the ground level too. Leadership comes from organizations who are doing this work. It comes from folks who are doing the face-to-face work with young people and their families. It comes from parents and caregivers and young people themselves. It comes from communities. So it's important for us to recognize where all the leaders are coming from, and to recognize that you are working within this system, that you play a role in this leadership by showing up, by providing feedback, by working to get it right, by not saying this system will never work, we're going to get frustrated and walk away, but actually by being good partners and sharing your experiences in ways that people can do something with that information and make it work. And I'll give you an example of what I mean by that. When we integrated youth with intellectual and developmental disabilities in 2012 and 13, we got a lot of things wrong. There's no doubt about it. And we got a lot of things wrong because we didn't have the right tools in our tool belt. We didn't have our workforce that was fully developed yet. We still had to bring young people and parents aboard in the conversation. There was a lot of work to do. And what I asked from all of our partners, number one, is to be kind to each other as we were working through these really difficult transitions. And two, to not get frustrated with the system, but to provide feedback, tell us how we're doing, and tell us in real time so we can do something about it. Don't go and tell other people that system doesn't work, don't call them. Tell us so that we can fix it and make it work. And we worked very hard to do that. And we had great experiences because of the feedback that we heard from every single one of our partners. And they all provide both positive feedback and critical feedback that was necessary for us to make changes as we went along. And I'll give you one of my big experiences in New Jersey. I traveled the full state to talk to parents on the ground, and I went to one of our more rural communities, and the room was full of people. People had traveled to come and see me and to tell me what a bad job I was doing, and then had no problem in telling me that, which was really helpful and phenomenal from my perspective. And we spent a lot of time talking about what the vision of the system was, but we also talked about where we were not getting it right. And I took notes and I asked them all, I gave them all my card and my email address and my cell phone number. And we worked through every single one of their challenges within it. And I said, I'll be back here next year. When I come back, I hope that you come back and tell me how I'm doing. I went back the next year, there were 3 parents in the room. And I asked the organizers why the room wasn't full. And they said, well, because you fixed the challenges for these parents, and they all just sent their thank yous. And the 3 parents in the room, by the way, hadn't been there the year before, but they were just learning about how they could use these supports and services. And so the lesson for that was how important parents' voice was, how important young people's voice was, how important our partners and providers in telling us their stories about what worked and didn't. As you go through this transformation, be kind to each other and share with each other what's working, what's not working. It's going to be incredibly important. It's also important to create the conditions that allow for shifts in language, to allow people to fail in that language message, right? I sat next to a parent in multiple meetings in New Jersey in the early days of the transformation, and she was pretty clear with me on a regular basis about language, right? Talking about children, youth, and young adults, and how I needed to get that right and stop using the word client as an example. Years later, I sat in the room with her as we were transforming and working to transform the services and supports for young people with intellectual and developmental disabilities. And she called them clients. And I said, when did that happen? Like, when did we begin to use that language again? So it works in a way in which we need to communicate on a regular basis and help people grow and learn that the language that they use is incredibly important. I work with some states that use jars in which they put money in the jars and they buy pizza when they get to a place. There's lots of ways to think about this, but one of the things you can do to help each other in this journey is really to get to a place in which you're all working together around language. You want to prioritize the voice of parents in every single part of the work that you do, and young people themselves. This is where innovation comes from. It doesn't come from just the systems, sort of being reorganized and designed. It comes from the actual impact on young people and their families. We want to focus on creating an access point that's easy for parents, which is what you're doing really well in trying to figure out how to get the resources to parents in the best, most efficient way. And you want to create those feedback loops and engage communities in supporting children, youth, and young and families. And mobile response and stabilization is one of the great equalizers in this work, and why it's so important in the conversation. And then we want to focus on the interrupting care pathways that take young people into the higher intensities of service. And as we talk about this work, I think it's really important for us to also say right up front that there's a group of young people who will benefit from a residential intervention, right? There are people who will benefit from that. What happens in a lot of systems is that we don't always get that part right. And so young people who will not benefit from those residential interventions end up getting into that. They get a residential intervention, and that's not the right place for them. So we want to design the system in a way that's going to address that right up front. Some of the leadership strategies we use to get there as we talk about systems design is really in how to handle this uncertainty, the rapid change. You guys are all going through this rapid change in Ohio in language and culture and access and contracts, right? And so you want to understand and communicate the vision of where you are, where you're going, and recall that vision when things get really mucky, as they will. And you want to find your champions and engage your new partners. And as you're thinking about this work, you want to really be talking to all of your partners. If you're in a residential intervention, that's where you're working, you're a QRTP or a PRTF, you're potentially doing that work. You want to make sure you understand who your community partners are and how they can be helpful to you. It's important that you pay attention to the partnership work. Who is it that we can have sitting at our table that can be helpful? But in all situations, no matter where you sit, young people and their families are the best partners within the work of transformation. So be transparent to families, providers, staff, and community. Talk to each other, right? Talk to each other about what's happening. What are you seeing? How does it work? What's working well? What's not working well? And one of the things that's really interesting from my perspective, having gone through this level of transformation, is when it works, when you get to a place in which those phones are quiet on Friday afternoon. It's really important to pay attention to the small steps in those milestones, and then the big ones, the big parts of your story in this transformation. And you want to share and report progress regularly. Develop partnerships with family, advocacy groups, providers, and be flexible and acknowledge what we don't know yet, because there's plenty of that, right? We're all learning on a regular basis. And we want to make sure that we're really moving the system towards trauma-informed care. And trauma-informed care is an approach to engaging people with histories of trauma, as I'm sure you all know. Bottom line on trauma-informed care is it really forces us to pay attention to what happened to young people and not gloss over that part of the story. We ask that question, what happened to you, of our young people? And sometimes we have to help our young people understand what happened to them, what happened to them. This is what happens to your body when these things happen to you. We want to create those three pillars of trauma-informed care, and it's important when we talk about residential interventions that we're really incorporating these three things: safety, affect regulation, coping, and self-management skills into all of the work that we do in any residential intervention. Okay, we have a question. I'm going to take this question because I think it's a really good one. What are your recommendations for caregivers who decline outpatient recommendation for children who are assessed to meet a level of care for intensive in-home behavioral treatment and intensive outpatient, et cetera, rather than residential, and parent is insistent they only want residential? And the answer to that question is really takes time to get there, right? So parents tend to ask for residential interventions because one, they're tired, two, they've been through a lot. They don't trust the system. They don't trust that the system's going to be helpful. But the other thing that happens is they don't really understand what residential intervention is, what it does, and whether it'd be helpful or not helpful for their child. And so a couple things to think about as you really think about this work. Number one, it takes time to help parents understand what a residential intervention is. And it's important in the conversation to flip residential on its head, right? So what parents think is going to happen is that a young person's going to go into a residential intervention and they're going to step back and it's all going to be quiet and their child's going to get better and then they're going to come home, right? And the reality is that if we flip that on its head, young person has a residential intervention, a PRTF or a QRTP. What happens, and mostly that would be PRTF, by the way, what happens is we need to spend more time, not less. We need to be more engaged, not less. We need to be really interactive with our children on a regular basis, not less. And that those requirements are not often laid out for parents, right? Right up front, and that's important. The other thing that I think is important to lay out is the impacts, right? The impact of a residential intervention. Why are you recommending, a clinical intervention such as intensive outpatient or intensive in-home service? Why do we think that that would be really more helpful to that young person? So I think there's a lot of considerations and a lot of discussion. My experience is that those conversations are really child family team conversations. I've had lots of them over the years with families. Most of them, we've convinced families that to try intensive in-home services, to try the supports, to put together a plan that's going to work for that young person. Because if the teams are not recommending that young people go into a residential intervention, and it's just the parent, then in New Jersey it wouldn't happen, right? We wouldn't have them move unless there was the full consensus of the team. This is why teaming is so important. And when I talk about teaming, I'm really talking about child family teams. And I'm talking about, not only am I talking about child family teams, I'm talking about that through high fidelity wraparound. So there's a process in which we're going through those conversations. I hope that helped your question. I'm going to continue to talk and move on, but I'm going to hit on what I mean by that. So we'll keep talking about this particular scenario of a parent who's not in agreement with the clinical recommendations of the therapist. Okay. We want to set this stage, right? This stage right here is important for families to understand that the new research on trauma suggests that, or supports that much of the healing for complex trauma takes place in non-clinical settings. And that means that we need to get those pieces right for families. There's a lot of these young people that you're talking about, they have these elevated stress systems, right? And those elevated stress systems are because of the challenges or issues around trauma. And so we want to actually reduce that stress system. We want to bring it into balance. And there's a lot of work that has to happen. So we also want to make sure that parents understand the sequencing of when and how interventions need to go into place. So trauma-informed living environments, so we can help families build that trauma-informed living environment in their own home, is where that healing can take place for a lot of young people. And it's the precursor to formal therapy, right? And formal therapy comes after, not before. And so it's important for us to understand that and then to be able to articulate that to parents in a way that they can understand as well. Okay, I'm going to touch on psychiatric residential treatment. There's one more question. Let's see if I can take that now. My question is around the conversation is what is the state doing to increase access to home and community-based services so we can aid in keeping children in a home so that parents may not feel that residential is the only option? That is a fabulous question. And you know what? I'm going to just say you're doing a lot of it, right? You're increasing access to intensive behavioral health treatment. You're expanding on mobile response and stabilization. You're working around building the care management entities. And we have folks from Ohio who are going to talk in a second, so we're going to let them address some of that question as well. But let me just lay the groundwork of what a psychiatric residential treatment facility is, so we can get to this actual real understanding of what residential is and what it does within a system of care. A psychiatric residential treatment facility provides an inpatient equivalent of care for youth with complex needs, right? So in other words, young people meet the criteria for being in an inpatient unit, and we believe they'll benefit from it. So that two-pronged approach of, do they meet the clinical criteria for inpatient? Yes. And will we think they benefit? Yes. It's trauma-informed, right? It's a trauma-informed approach to providing that residential intervention. The intervention is necessary to the youth's complex needs, right? There's a lot of things that are happening around that young person that requires this intensity of work to be done. It may include youth with child welfare involvement, but it's not only, right? And the majority of young people in most states don't touch on child welfare in order to touch on a psychiatric residential treatment facility, PRTF. All youth referred with clinical need are accepted if a bed is available. So in other words, if the young person meets those criteria, as we just talked about, that clinical criteria, they're at that hospital level, there's a bed open, they go. It's not this process of, should we take them, should we not take them? They go, okay? That's where they're gonna go to get the treatment. Engagement is in the treatment process is a driving value. So we're getting to that engagement discussion that we talked about earlier. And the team focuses on transition as part of the admission process. So part of the conversation right up front, right from the door, is that what's going to happen for that young person upon transition, right? And that you recognize what good psychiatric residential treatment partners recognize is that there is challenges around young people entering, around transition into and transition from, and they plan those to address those challenges, the behavioral challenges young people might demonstrate, engagement challenges, developing community engagement strategies with these young people. But they built that into into that whole treatment process, and so they know that there's nothing that's going to happen in this treatment intervention that's going to extend their stay. So we have a game plan from beginning to end, and where that young person is going to go upon transition, and how we're going to support them around transition so they're back in their own communities as quickly as possible. Youth return to the community at the completion of treatment, right? They move away from step down, so they don't move. We're saying psychiatric residential treatment facility is really the highest level of residential. We're not saying you're going to step into a group home or another residential intervention. That's not how it works. You get what you need in the treatment intervention. It's designed to meet your unique needs, designed to address transition from the start, and designed for the young person to return back to the community. That's all part of the treatment process. Okay, Marisa or Kelly, did you want to jump in here and talk a little bit about what Ohio is doing?
Absolutely. Thanks, Liz. So good to be with everyone today. I'm Marisa Weisel from the Department of Medicaid, and we've been working on Ohio Rise, as many of you probably know. The Ohio Rise program will feature a number of new behavioral health services that will be available to children only who are enrolled in Ohio Rise. These will add on to the existing behavioral health services that we have in our benefit package today. You can see the names of the other services up here across the top, but specifically today we're talking about psychiatric residential treatment facility services, of course. It is our goal with the PRTF service to provide a very high quality inpatient level of behavioral health treatment services in a residential setting. And this is actually a little bit confusing because when we kind of think about what's an inpatient level of care, we often think about what happens today at our hospitals when a child is admitted for psychiatric services or substance use disorder services. They're there for, 3 to 7 days. There's it's really about stabilizing a child, making sure that they are safe and others are safe, and then getting them back out into another place of care. For those children who really could benefit from the highest level of care, maybe following that or instead of that, that might last, weeks or occasionally months, the children who need the most intensive interventions in the residential setting would possibly be eligible for this PRTF benefit in Ohio. The idea is to quickly stabilize behaviors more than you would have in an inpatient level of care for a longer period of time, treat symptoms, and help them come back into a family-based setting. And as Liz either probably has said or will tell you later, it's not our intention to have PRTF be a level of care where you then step down into another residential level of care at, say, a qualified residential treatment program. Instead, PRTF is supposed to be good enough to get you back to the community afterward. And Ohio's approach is to help keep developing this new service as part of our benefit package is part of our approach to help keep children in state. So, on any given day, we probably have 140 or so kids who are being served in residential treatment facilities outside of Ohio. And many of those facilities are PRTFs in other states. And so by developing the service here and having provider capacity for this level of care here, we hope that we don't have to send as many children out of state. We also, the benefits of having this here versus in other states means that we can reunify children with their families and community supports by having these facilities in Ohio and having children connected to the rest of the system of care within Ohio Rise. the care management entities that we're developing that will do care coordination, and Aetna's care coordination as our Ohio RISE plan will help make sure that they're reaching in and working with the PRTF to make sure that as kids are discharging, all of the supports that they need are in place so that they can actually discharge back into a family-based setting. And those CMEs and the PRTFs will partner as the child exits, potentially partnering on, home visits and other ways to help make sure that our community networks around kids are ready. And then where appropriate, we will actually have PRTFs have some of the same qualifications as our QRTPs. Next slide. In Ohio, PRTFs will have 3 entities that they get to work with, much like all of our other behavioral health providers. There will be licensure and certification standards, including those around seclusion and restraint that are governed by the Ohio Department of Mental Health and Addiction Services. Providers that want to be a PRTF will have to get that licensure and certification. Then they'll have to contract with ODM as a provider. We have some rules and some draft rules that are linked here about how we will cover the service and its limitations, as well as the requirements for cost reporting. And then Aetna, the Ohio RISE plan, will selectively contract with PRTFs to make sure that they have just the right number of beds and access that we need, and they will help authorize services based on medical necessity criteria. Ooh, that's tough on Friday. Next slide. The work that we're doing in the PRTF space right now is actually focused on rate setting. So those draft rules that are linked on the previous slides help outline what the requirements to be a PRTF would be and who can be served in them. Now we're working on, once they're getting services there, how will we pay those providers? And this is a really very detailed process that we're working on with our actuaries that contract with Medicaid. They're called Milliman. And so we're working with a subset of residential providers and other folks to help us make sure that when we set the rates that they are sustainable and correct. So we're doing things like trying to understand how those potential PRTF facilities operate today. What are the things we'll expect them to do based on our rules? We're surveying those providers. We're analyzing a bunch of data, including data that we have at Medicaid, but also data that we have from our partners at JFS about the facilities that currently serve children in the 4E space. And then we will establish rates. Next slide. Right now, we're in the process of conducting some of those provider interviews. We have a rate setting subgroup that will really get into the technical details of this, and we'll meet monthly for quite a while. Again, we're bringing in the JFS data, and then we'll have a preliminary rate setting methodology that we'll put back in front of people and so that they can provide us some feedback. Next slide. And here's the overall timeline. So we already did our PRTF work groups around developing the service regulatory structure. Now we're doing this rate setting. We'll eventually be filing some rules along with the rate information. Ohio RISE goes live on July 1. We'll still be working on the PRTF service while that happens and while we're developing and implementing the community-based services. And then 6 months later in January, our PRTF service will go live. Back to you, Liz.
Okay. Before I go to no eject, no reject, let's talk a little bit about some of the questions that are arising. So I'm going to get back to that question. My question around this conversation is, what is the state doing to increase access to home-based services so we can aid in keeping the child in the home so that parents may not feel that residentials are an option? You want to take that one?
Sure, unless you'd like to, Liz. It's a really good question, and it's hard. I'm not gonna sugarcoat anything here, and I wanna make sure that we're all realistic about our expectations. On the first slide that I had, there were, a number of subsets of services listed across the top that are all new and enhanced for Ohio RISE. And the process the tools that we have at the state, at least from a Medicaid perspective, are we can pay for things. And we can do things like use a managed care plan and the managed care tools to help us develop services. So we've established new services that we want to have available, and we've enhanced some of those that exist today to make them easier for providers to do. We've set rates at a place that we think is really positive and sustainable. We've helped fund and are implementing a center of excellence that will help train up providers so that we have a workforce that knows how to do the evidence-based practices that we need to have available for kids. And then we'll monitor the quality and help us improve the quality of those services over time. Where the rubber meets the road, though, is workforce challenges. And that's where, you know, we are hearing so much feedback today. I'm sure this was a challenge before the pandemic, and it's even more challenging now. So we are partnering heavily with our colleagues at Ohio Moss and across the other state sister agencies as we all think about workforce across all of the human service types of care that folks are getting that are funded by Medicaid and other sources. And there's a lot going on in that space. But again, I don't want to sugarcoat this and say that it's going to be easy to develop provider capacity here, because we're drawing on the same workforce for a number of our services in the Ohio Rise space. And we're doing what we can, but we know this is going to take a while. And even in other states in non-pandemic times, this takes years.
Yeah, I can attest to that. It does take years. Listen, there's another question, Marisa, I think that might help. Some folks are confused just what Ohio Rise is. So if you could do a quick overview, that'd be helpful.
Oh, I'd love to. Thank you. And we have so much information on our website that we'll drop the link to in the chat. Ohio Rise is a new program that will be offered for children in Medicaid. Today, you know, nearly everyone in Ohio Medicaid has a private managed care plan that helps pay for their benefits and manage their care. The construct that we have today is, you know, there are 5 managed care plans. You might have heard of, you know, CareSource, Molina, United Healthcare working in this space. And they all manage all the benefits for all the people. Ohio Rise, as part of our next generation of managed care in Ohio, takes out a subset of services and a subset of kids to really focus on them. And the kids that we've pulled out, will pull out starting in July, are those who have the most complex behavioral health conditions and multi-system needs. And the services that we're pulling out for them at the same time are the behavioral health benefits, so that we can really concentrate on doing better for that subset of the population and doing better on developing those services. And there's much more information on our website.
Thank you. I think that's helpful for folks to be able to see all of the work that you're doing. And I'm just going to put a plug in for the work of Ohio Rise, recognizing that, you know, the customization for this particular population is really necessary, because they tend to get lost in the larger adult world. They get lost in the medical world, and really having specialization for children and families is just really important. So it's a really important work that's happening at Ohio Rise. You know, I've been watching the work for a while, and just really excited about, you know, where you're at. And I know it feels like you're in the early stages, but it's really important work that's happening currently. I think we have one more question that might be helpful for you to take, and that well, maybe 2. One is the age that you're looking at for PRTF, and the other is really around how many providers, or do you have providers that are currently working through the process?
Thanks, both good questions. For PRTFs, this is within the Medicaid world. There are a lot of federal regulations and guidance around what a PRTF is, and our federal partners at the Centers for Medicare and Medicaid Services help us understand how we need to implement a PRTF benefit in our state. And their rules are what we're aligning with here in Ohio. While we, you know, will make the benefit available to our younger kiddos, we anticipate that most who will be served in PRTFs are probably, you know, 10 or older, 12 or older. I'm sure Liz can tell you what it's like in other states. And the top limit on PRTFs is, let's see, until you turn 21, unless you're already in the PRTF. And in that case, you can stay until you're 22.
Yeah, those are the rules, right? Those are the rules. Right, as they're organized. I'm going to argue that, you know, any kind of residential intervention for young children is just not advised from a clinical perspective. And so we definitely don't want to move in that direction. And then, and really it's a certain part of the population that are going to benefit the most from this particular intervention. So the other thing, one more thing before I let you go, and that is, or till any other questions come up, and that is around you're thinking around the connection for, or outlining the care management entities and their role, because I think that's going to help answer some of these questions around what else can happen, even if it can't happen now, what the vision of the future of what will happen for a lot of these young people and keeping them in their own homes.
Thank you. That's a great point. So all children who enroll in Ohio Rise will have a greater level of care coordination offered to them today as a Medicaid benefit or service than they do now. That's part of the reason that we're enrolling them in Ohio Rise, is so that we can intensively work on coordinating their care and offer them not only access to Medicaid services, but also think about the other community-based and natural supports that they would need to help sustain them once they hopefully exit out of the Ohio Rise program. The care coordination approach is all based on system of care principles and high fidelity wraparound. And that is the type of care coordination that in other states and jurisdictions has shown to be really positive in being able to help a child and a family move beyond some of the behavioral health treatment challenges that they have, get access to care, and then have better health and life outcomes. In Ohio, we're developing catchment areas that will be served by one care coordination entity each. It's called Care Management Entity, CME. And that CME will be responsible for delivering intensive and moderate care coordination to children based on these principles that are very family-based, child-based, strengths-based. It involves a very prescribed child and family teaming process to develop a care coordination plan and implement that plan and make sure that that plan is working over time. And the connection to PRTFs here is, in an ideal situation, we'd have a child in Ohio Rise, they'd be connected to their CME and care coordination process. You'd try a number of interventions that maybe weren't working, or there might be some sort of thing that happens in a child or a family's life that might require them to need more intensive services. The care coordination, care management team and the child and family team would be part of the decision for a child to go to a PRTF, and then work on discharge planning, from the day a child goes there until the time they get out. That's the ideal. We know that particularly at first, as we have many children who might need this level of service and may not have had access to some of the lower intensity interventions, that we'll have kids who are in PRTFs that just need help getting out, or we'll have children who really haven't had a chance to mitigate some of those challenges that they and their families are having in the community. And so I expect that at first, the CMEs will mostly be involved in discharge planning and helping kids get back connected back to services once they're in the community.
That's great. One last question before you go, because I just saw it, and that is, will the PRTFs be required to take admissions 24/7?
Oh, that's a good question. I don't know the answer to that. I would hope that we're, doing some planful admissions to PRTFs and we don't need to have them take admissions 24/7. But I do not know if that's in our Medicaid rule or the Ohio MOS rule. We can look into that.
It's and I can tell you that it's not best practice to admit a child in the middle of the night. It's just not good for them. It throws their systems totally off, and it doesn't do what we need him to do, and that's that planful, engaged process of admission.
Thanks, Liz.
You're welcome. Thank you. I might have other questions that come up, but thank you.
I will be here
Perfect.
For a whole 20 minutes, and then Kelly will be here after that.
Perfect. Thank you so much. Okay, Mike, there's a question in the question and answer. I don't know if you know the answer to that. County workers and placement processes are also a factor in the moving youth to residential versus foster care homes. Will that work be done by the Children's Services Department? Do you want me to go through the QRTP work first, or is there a chance you might be wanting to answer that question?
Thanks for that. It can be a two-part. So yes, if the child and family have active involvement with Child Protective Services with a PCSA in Ohio, then absolutely the PCSA case carrying worker would play a role in that decision-making process. But I do think it would probably help to elevate the difference between PRTF and QRTP to context. You
got it. I'm happy to do that. There's a couple other questions in the Q&A that I'm going to put off for a little bit. I'll get back to them. They're really about individual young people, and that's a different question. So let me do the big, broad questions and the big, broad work around systems transformation, then we can get to what the impact is for young people. So let's talk initially about what no eject, no reject is and why this is an important concept in systems transformation. The no eject philosophy allows residential teams to focus on engagement strategies to meet the needs of youth that the PRTF is designed to serve. In other words, we take the decision-making part out of it around whether they should take them, not take them, whether they fit the milieu, don't fit the milieu. And I know that not a lot of residential intervention programs are designed right now to do that. I actually ran one that was designed exactly for that purpose. Someone else made the decision that the young person should be admitted. We had a bed, we took them. That's the way PRTFs are designed to operate, right? So this is the clinical criteria. These are the young people that we serve. These are our specialties. And so we have a bed, young person comes. What it allows you to do is reorganize your teams and the residential folks within those teams to be able to meet the needs of these young people. So it's really thoughtful and deliberative process, more so than it sounds like, right? So it's important for us to think about that. A no eject, no reject policy or philosophy allows teams to focus on necessary clinical interventions to meet the youth's needs, recognizes the crisis points within the treatment experience, and works to prevent escalation of behavior, moves away from coercive interventions. And I just want to say that New Jersey's system of care is designed as no eject, no reject across the full system. There's no part of the system that is allowed to say, no, we're not going to do that. Mobile response and stabilization gets a call, they go. Intensive care coordination has a young person assigned to them, they begin their work. That's just the way the whole system is designed. And so we get away from this idea of whether they're good fit, don't fit, whether we can help them or not help them, to the place of how are we going to help them. And it's just an important design or philosophy within the work itself that recognizes that young people's needs are important. We're going to prioritize them. We're going to do everything that we can to help them feel better. So let's talk about a qualified residential treatment program. What is it? A QRTP is really this idea that came with the Family First Prevention Services Act work. And the idea really was to improve the quality of care for young people in residential interventions, right? So these young folks are they're child welfare involved. They're going to meet the criteria for 4E funding, which means that the federal government will use non-Medicaid dollars to pay for these young people. For majority of them, their residential needs do not meet the criteria for QRT, for a psychiatric residential treatment facility. The QRTP focuses on improving the quality of care for youth in group care. There's an assessment within 30 days, it's trauma-informed, and there's court oversight. So some differences you can begin to see between the QRTP and the PRTF, right? The PRTF is this medically driven, if you will, idea. The young person meets the criteria for hospitalization, is admitted into short-term residential intervention. The assessments are done prior to or right at the time of admission for young people with PRTF. You can see there's a delay here. There's some child welfare activities that are driving the need for the QRTP experience, okay? So, but the overlapping quality for those residential interventions is where we want to talk about some of these conversations, right? And that's when we're going to get to residential best practices. And these residential best practices matter not just in psychiatric residential treatment, but also in the qualified residential. So the Family First Act, for folks who are not familiar, allows every state to put together a plan that how they're going to use their 4E funding for the first time ever to provide services in a prevention manner, right? We can provide services for youth who are at risk of foster care rather than having to go into foster care in order to access. any of the services. So it's a really different way of thinking about it. And the purpose is to increase the quality of care for children within a residential intervention, as the QRTP requires nursing, 24-hour access to nursing, which was really new in the world of residential. Not all residentials had access to nursing 24/7. It's required to provide family-based aftercare supports for at least 6 months post-transition. So in other words, a young person completes or finishes in the qualified residential treatment facility, they return to their community with 6 months worth of aftercare services. It limits 4E within residential to the qualified residential treatment program. In other words, if it's not a qualified residential treatment program as designed by the state, and what that means is it's providing those quality interventions, which we'll talk about, then the 4E won't pay for it unless they meet these conditions. It's a prenatal or postpartum parenting support for young people. It's supervised setting for youth over 18 who are living independently, or high quality residential care for youth who are at risk of having experienced sex trafficking. And then foster care is also carved out for that, okay? Let me get to best practices, right? And best practices for residential doesn't matter from my perspective, whether it's a psychiatric residential treatment or qualified residential treatment program, okay? When we're talking about residential best practices, we want everyone to be moving in this direction around particular things. Like we want it to be a home-like environment, or we want it to be trauma-informed. And what that means in trauma-informed is we want the environment within the home to be trauma-informed. We want the furniture to be comfortable, right? We want young people to be able to get food when they're hungry. We want there to be rocking chairs. We want sensory tools. We want the staff to recognize the young person's past trauma history. Because the goal at the end of the day is for young people to feel better and not actually to get compliance. And what we mean by that, as it came up earlier today, compliance means that young people will say, yes, I will do what you say. I won't necessarily agree with it, and it might not necessarily help me in the long term, but I'll do whatever I have to do to get out of here. So either I'm going to act out to get out of here, or I'm going to just comply with your rules, right? And the compliance factor is really problematic within residential because it doesn't get us to what it is that's necessary for the young person to actually use that experience to get them moving in the direction that we need them to move, right? So compliance isn't really helpful. And we can get compliance, right? We can use tools to get compliance, but it's not helpful for young people in the long term. And some of the reasons we use compliance as a measure, right? Their behavior improved. We stop seeing them do particular things. We use point systems to guide us, and that really have not been demonstrated to be helpful over time, right? So a couple of factors to keep in mind. One is in order to get away from this idea of compliance, we as adults, as people who care about young people, need to show up for them. And so when a young person goes into a residential intervention, we're going to flip that on its head. And instead of saying you're away and you're going to get better and then you're going to come home, we're going to say, no, we're going to increase our activities. For those who are providing high fidelity wraparound, we're going to see you more often. For those of you who work in child welfare, we're going to see you more often. For those of you who are working in juvenile justice, we're going to see you more often. For those of you who are just carrying adults in the child's life, we're going to pay more attention. We're going to write, we're going to see you, we're going to FaceTime, we're going to visit, we're going to do everything that is necessary to help you know that you're part of this community, and not a thing is going to change about that until we can get you back here in this community. So there's no breaks for the team, right? The team works harder when young people are in residential units. We expect more. The system should apply more pressure to make sure that those contacts are more frequent, not less frequent. And it's important for us to be able to do that in systems design. And there's important data that we learned certainly from our experience in New Jersey, and that is that there's diminishing returns on long length of stay. And I've said this before, I'm going to say this again, that I didn't go to work for the Department of Children and Families in New Jersey to fix residential care. I went there to integrate youth with intellectual and developmental disabilities, to expand out services for young people with substance use challenges, and to do some of the creative work around building care for young people who have chronic medical conditions and co-occurring behavioral health needs. And so I was really interested in that work. But as I said before, my history is in, I started my career really in the residential world, and have some real strong beliefs that young people don't do well when they're restrained, and there's seclusion and coercion. That those things are not really helpful tools in the tool belt. And what I learned when I went to the state is that we had some residential partners who were not moving towards best practices. And that because of that, I had to really pivot in my time and say, we're going to improve the quality of care for young people in residential. And we took some really important and thoughtful steps around the work that we did, including some work that had really started prior to my going to work for the state, moving to these home-like environments. So almost all residential interventions in New Jersey are in these small 5-6 bed programs. They're not in large campus programs. There's a few, but very few compared to most states' work. And that every program now in New Jersey is trauma informed and has had not only training, but coaching and some tools put in for the teams to have an ongoing training around particular tools that we use around trauma informed care. All of the programs have had a visit from an occupational therapist who have helped them build sensory tools, sensory rooms, help design those tools, help staff use those tools in a way that is meaningful. All have worked to begin to use begin the conversation around engagement with communities and working with high fidelity RAP teams around how do we make sure that we have community continue to be engaged when the young person is in residential intervention. So all these things are just food for thought for all of them. Some other residential best practices. Like, do you have a question? Something come up?
I was just going to maybe circle back to the second part of the answer with respect to QRTP and the qualified individual. Is this a good time to?
Absolutely.
Okay. So for those who aren't aware, the Family First Prevention Services Act, all of the provisions around QRTP require that a qualified individual do the independent assessment to determine, is this the appropriate level of care? And as was talked about earlier in this session, unfortunately, historically, we have children and youth who are in congregate care settings when maybe that isn't the appropriate level of care and doesn't meet their treatment needs. And so this federal act was really designed to make sure that we're answering the question, is this the appropriate level of care, and who's making that determination? So Ohio has selected the CANS, the Child and Adolescent Strengths and Needs, as our assessment tool, which aligns with Ohio RISE. And that was an intentional strategic decision. So the qualified individual is responsible for conducting the assessment. What's really important as it relates to the question that was asked in the chat in terms of who's making decisions, the CANS assessment process is meant to be done in conjunction with the family and permanency team, with input from the youth, and ultimately to reach a consensus, to explore lower level of care options, and to include youth voice and choice and family engagement in those decisions that are being made. So the direct answer to the question is the qualified individual really is making a level of care recommendation to the court, but it should be done so from a best practice standpoint with input from the entire team in an iterative manner, where we're reaching conclusions over time and not simply checking a box to say this is the right or wrong decision. So hopefully that answers the question.
That's helpful. From my perspective, that was helpful. Let's just talk real quick about the CANS, because I think it's important for folks to understand how the CANS works and how it will operate, not just now, but in the future around the care management entities. And the CANS, or the Child and Adolescent Needs and Strength tool, is a communimetrics tool, which means it's designed to get people talking and communicating. And as you heard me talk earlier today, communication is the number one thing that gets in the way of good care for children, right? So this communimetric tool forces folks to the table to have real conversations, both about what are we worried about in addressing and finding needs, but also what are the strengths for the young person and how we can use those strengths for the young person and for the team. How do we use those strengths to be able to provide the best plan? And for young people, how do we give evidence to those strengths, right? Because most young people don't actually believe us when we tell them that they're really good at things, right? So that CANS assessment approach is really important. So as Mike talked about, it's done by the independent assessor, but are there other places in the system right now that the CANS is being used, Mike?
So limited, but I know that with the future rollout and the future vision with Ohio Rise, it's going to be used for, and I know Marisa and Kelly can speak to this more specifically, but it'll be used for admission and it'll be used in an ongoing manner along with an array of other assessment tools. But I also wanted to tie up some of the earlier concepts you talked about with respect to what's required with a QRTP in terms of aftercare, trauma-informed care. When we think about the paradigm shift of the future state we want to be in and what this federal legislation is pushing for is that when a child enters residential care, a QRTP, that it's done so with intention, with an assessment, but also with a planning for the exit from day one. That we're thinking about what does step down look like in the shortest time possible with family at the table and with those wraparound supports when step down happens. Mm-hmm. And unfortunately, that's not our current state of practice. And that's the state we want to get to from a consistency standpoint.
Yeah, and I'm going to say that best practice even moves away from the idea of step down, right? It moves into the place of community. We're going to move you from, when you've completed you've met your treatment goals, we're going to actually have you re-engage in the community, right, in a way that's meaningful. So, and that helps your state really begin to think about, we're not going to go from residential intervention into a therapeutic foster, as an example, right? And why wouldn't we do that? The way to think about it is every time we make one of these decisions, right, around a young person entering a treatment intervention, any treatment intervention, we take them developmentally off of the developmental path, right? And because we do that, because we pull them out of their normal, adolescent development activities for adolescents anyway, we really need to have a really good reason to do that, because getting them back engaged in those activities becomes really complicated. And so I support this idea that you're really thinking transition from beginning. It's really important in the world of what's going to happen from beginning to end. And I would even support you moving away from the language of step down. Even if it's step down, it's still going to happen. Just so people get in their minds, we're not doing step downs. We're doing.
Yeah, no, I appreciate that very much. And I think it also fits well with the lens of like, this process isn't about putting a child into a setting, fixing them, and then putting them back into relationships. It's about using relationships as the platform for healing. So I appreciate that challenge on the step down framework that somehow you're in a setting away from, right? But ultimately it's the community and family engagement that's a part of the treatment. That's and right. not an on-off switch. So I appreciate that.
That's right. And that's why this idea of compliance, right? That we want young people to comply and then they can come home, right? And that's what we tell them. If you comply, then we can get you out of here. What we really want them to do is heal, right? And because they're on a healing path and they're beginning to feel better, then we're going to continue that healing process as they re-engage in the community, the other developmental activities that they are not allowed to do during the time that they're in residential intervention. So just really important components of that, I think. Okay.
And Liz, this is Kelly.
Yes.
Just wanted to also talk a little bit about the CANS and its use. So Mike is right. It is limited right now. The folks are using it right now for QRTP level of care assessments, but in the future, and I think DYS or the DD space is using it for ICF rate add-on beds to determine eligibility into those. But we do anticipate that, come July 1, when we turn on Ohio Rise, we will see a lot of folks using it for eligibility determinations into Ohio Rise, as well as level of care recommendations, ongoing assessments. So even in PRTFs, those assessments will take place. And then so right now, the state of Ohio, ever since I think around August, we've been sponsoring CANS training to make sure that we have those assessors that are available for these purposes moving forward. I think we have over 300 people who have become certified in the CANS tool as of a couple of weeks ago when we provided that information at our advisory council meeting. And then we have, we've been working with the COE so that they can take over those trainings in the beginning of the year.
Great. Listen, the CANS is incredibly important in as a tool, not only for the decision making that you're talking about, which is important, but also the idea that young people will be viewed from the same type of lens, right? So we're not using this assessment tool, which might give us different ideas about what should happen to young people. The other reason that it's so important is that community-metrics component to the CANS that allows us to talk to each other. And so there's a question in the Q&A that asks the question, what provider roles are recommended to participate in the CANS training? And so Kelly, I don't know if you want to answer that particular question from your perspective, or whether or not you want me to try and take it from a best practice perspective.
I think that's a good question. And I think it varies because of just what you mentioned. It's going to be across systems. So it just depends on who wants to use the assessment. So some organizations who have trained staff and they want to administer the CANS, they can provide that assessment. And then those without trained staff, they would want to refer to other organizations so that they can get that child assessed. I guess if you have a child in front of you and you have somebody who could deliver the CANS assessment, then you could identify them much quicker and get them into care faster.
That's right. That's absolutely right. And that's a good way of thinking about it. And I think one other thing I would say is that that I think is important is that even if you're not a CANS assessor, understanding how the CANS works, because if you're at any planning table, you want to understand how the CANS works so that you can answer, and support young people by making sure the right information is on the table, right? We tend to think about, and the worry in New Jersey when we were rolling out the CANS is that people would, answer questions in a way that would have some young people in higher intensities of service than was necessary. And yet what we learned is the more we understood how the CANS operated, how it worked, it would allow us to get the right things in place for young people, right? And that was more important. So it didn't matter whether it was a high, some people need and benefit from a PRTF. And so from that psychiatric residential intervention. And so we want to make sure that they get it versus young people who would benefit from intensive in-home services as an example. And our job was to get the right service in the right time for the right duration, not, overestimate young people who are going in. But what CANS did was allow that to happen. So it's a really thoughtful rollout that you're doing in Ohio. And I think folks, the more you get to know and understand how the CANS operates, the better off I think all of you will be in the planning for young people. So there's another question that I'm just going to take real quick, and that is define a long residential stay in months, weeks, years. Yes. So I will never describe a good residential intervention as taking place more than 6 months. And I'm gonna, I think it's important to know that residential interventions are not more successful if they're longer, right? So 18 months is not gonna be more successful. But we did a drill down of, and I think we looked at 250 or 300 young people who had touched on a residential intervention in New Jersey. And in that work, we learned that young people who were in a residential intervention for less than 6 months, returned to the community, actually did well. Their long-term, because we could see the long-term data and where they were at, not just in 3 months and 6 months, but a year, 2 years, 3 years later, were doing well. They were in school, they were doing well. For young people who were in a residential intervention from 6 to 9 months, we started to see significant diminishing returns. And after 9 months, we saw almost all diminishing returns. And so important to recognize that more residential isn't better, right? Good residential is best, right? So we need short residential interventions. Young people really can't tolerate any intervention for at least from what I can see for longer than 9 months. High fidelity wraparound, as an example, for most young people begin to really see diminishing returns after 12 months. Challenge there is that parents and caregivers tend to do better at 16, like they feel well supported at 16 months. So, you know, high fidelity wraparound teams are always sort of managing in the middle of that. So important to know, more isn't better, right? Multiple admissions isn't better. Trying the same thing over and over again isn't necessarily the best answer for young people when it comes to residential. So I hope that answered that question for you. Okay, and one more came up. So as we do cans for QRTP placements right now as part of the Family First Prevention Service Act and prior to Ohio RISE rollout, I know Medicaid has come out with billing and advisement. I'm wondering how anyone is advising OBHIS with this process. For example, in my EHR to bill service, they'd be in mental health or SUD program, which automatically requires OBHIS data, and this will increase our failed reports with that data. So I'm not the expert on that, but I'm going to put it out there for folks from Ohio who might be able to answer that question. And if not, we'll try to get you the answer to that question. And I'm going to just get ready to move on to best practices. Kelly or Mike, do you know the answer to that question? That was a lot.
Way out of my league, sorry.
Okay, no problem. Let's see if we can try and get that answer for folks who are guide them.
We can take it back.
Thank you. Appreciate it. Okay, residential best practices. Let's start with, these are just best practices for all residential, right? Doesn't matter whether it's the psychiatric residential treatment or the qualified residential treatment program, right? The connection to home and community-based service is important, right? Making sure that young people are staying connected to their home and to their communities is really important. We need to make sure that it's strength-based, that we're finding the strengths for young people. This is why the child and adolescent needs and strength tool is important. It actually allows us to identify the strengths of young people and their family members. That moving to no eject, no reject is really an essential philosophical shift. It takes time for states to move and orient in that direction. It takes a lot of time for providers and partners to move in that direction. But for anyone who's listening today, I would say you can begin to ground your own practice in this idea that we're not going to kick children out and we're not going to say no to the individuals that we can serve. You can begin to shift your own practice in that direction before there's a formal policy at the state level, as an example. We want to match youth to the best residential intervention to meet their needs. One of the challenges that states have across the country, and I see this all the time, and it certainly was an issue for us in New Jersey, was that we did not match young people with the best residential intervention for them. What we did was find open beds. Open beds to the wrong residential intervention for young people is not helpful because it forces movement up or movement it forces these treatment failures, we should say, okay? We want to make sure that we're doing individualized planning and we're bringing all the people that are really important to the young people together on a regular basis to talk about it. So we're not just doing this treatment planning process, and the treatment planning process means that we bring the treatment team from the residential together to talk about the young person. No, it means we're bringing parents and we're bringing community members, and we're really running what we call child family teams in that, rather than treatment teams. You might.
I just wanted to add one thing, just to tie one of the values you talked about early on around shared decision-making and sharing power. And my experience has shown that families and community members that you're talking about, they know when they enter a room and a decision's already been made. They can feel it, they can sense it. And so one of the things that I would add to bringing to life a lot of these best practices is asking yourself before you enter meetings and before you talk to other professionals, how are decisions made today? And how can we make decisions differently together in the future? Because sometimes that requires structuring meetings differently. It requires meeting in different places. But really asking yourself on a regular basis, how am I making decisions? How are we making decisions? And how can we include family before those decisions are being made? So I just wanted to throw that out there.
I think that that's a really excellent point. And I'll just add to that by saying that in the world in which child family teams are the drivers of decision making, it doesn't matter where you are in your power and your authority, you don't overstep into child family teams. So I am incredibly respectful of the process of child family teams. I believe that they're really important in the decision making, and that any decisions that child family teams make are the ones we're going to be respectful of, right? And so we've designed our whole system in that way, right? Child family teams make a decision, they submit their recommendations for treatment. And let's say they make a decision that the team comes up with the idea that residential intervention is necessary. I, at the assistant commissioner position, doesn't come in and say, no, you can't have that, right? Sorry, that doesn't work. No, even the folks who are overseeing, right? So from a philosophical perspective, right, that ASO-like organization, its job is not to say, sorry, you can't have that. What their job is to say is, we don't have enough information to understand how your decision was made. Can you share more with us about how that decision was made? And that dialogue or conversation around that allows us to get to some really good decisions, right? And so that shared decision-making is so incredibly important. And any place that you come into the table, the idea that your mind should be able to be changed is important. The first child family team meeting I ever attended in New Jersey, I was the director of the residential programs and the partial care program for a large community behavioral health organization. And I went into the child family team in a family's basement and a big table and lots of folks I had never met before at the table. And my job was to go and to tell that team that this young man needed 5 days of partial care treatment. And I left there thinking he should be playing football. And I was right, he should be playing football. He should not be in partial care treatment. And we could stand on the sidelines and support him and help him if he began to stumble or fall. We were in his corner. So that's the way that shared decision-making is just so important, right? We're here to help you, but this is the right decision for you, right? Because you've made it, not us, right?
I love that example. If I could just add one more before you move on. From my experience, when you enter with that curiosity and that willingness to partner with families and to listen and to challenge your own assumptions, my experience has been 9 times out of 10, the solution we land on was something I never could have come up with as a professional, right? And so being open is the key.
Yeah, that's so right. And you know what? I fell in love with child family team meetings on that day. And I actually moved away from that organization and started to run child family teams, because that's how powerful that shared decision-making is, and how important it is for professionals just to lend their expertise in what they're worried about, and recognizing that there are many solutions, right, to the problem at hand, and how that team comes up with those solutions is really powerful. So it's all fun. So we want to do that individualized planning. We want young people to get what they need, right? We want coordination across programs and systems. We want people to talk to each other. And so that we don't have to say things like, and you probably have said these things, we have said them, I have said them, you have to do this, you have to go down the street. Sorry, you have to hit this criteria over there. I can't help you, I wish I could. We want to be committed to health equity and making sure that that access to whatever it is necessary for young people or families is not complicated. Commitment to natural helping networks, and that's the first place we're going to turn to help families. It's not the last place we're going to turn. And that we're going to do work around community engagement strategies that allow us to find places in the community that bring those natural helping networks more to our table, and that we're resiliency oriented, both for young people and for their families. Some residential best practices that are important is this trauma-informed lens in which we're going to look through that lens. But the other part of that trauma-informed care is we're never going to lose sight of the fact that young people have experienced particular trauma. Once we know that it exists, we're not going to forget it down the road and then say, well, you know, they keep acting out on this particular day, right? If we look at the record, we can begin to see where the trauma was and always work in the direction of healing and support for those young people. Sorry about that on the slides. We need to focus on workforce and you know, listen, the workforce challenges that you're having in Ohio are certainly not unique to Ohio. There's not a state I'm working in that doesn't have these ongoing challenges. However, just some thoughts around workforce development and some shifts. Number one, if you shift away from residential interventions, you know, in the larger, you can begin to sort of reorganize the tables in which people begin to sit at. But even more important, I think, than that, the most important part of the work is people feeling good about the work they're doing, feeling good about how they're impacting the lives of young people and families, and then bringing their friends to that. So in the workforce development strategies, we work with universities and the Center for Excellence and all the folks that you want to work with. But some of the real interesting work was how people brought their own friends and their recent college graduates to the table to begin to do this work. You also are doing a lot of work around the Center for Excellence and building the expertise, which is so important. And we keep an eye on that work and how the Center for Excellence will make a difference in terms of the workforce and bringing people to the table. We want to create environments in which both professionals have the opportunity to learn and grow and learn together and bring them together. But we also want to create environments in which young people experience healing. We want to think about the programs, right? We want to think about what's actually happening in those programs, what's going on. We don't want residential interventions to sit to the sides and say, when young people go there, we don't know what happens, right? It's important, if you have a role in a young person's life, no matter what that is, it's important to know what's happening in those residential interventions. It's also important for the residential intervention partners to know what all of you do, right? How you can be helpful and part of the solution for them. And then this pretty controversial statement, I'm going to say that point systems are not helpful. It's not just my opinion, by the way. There's been a lot of work that has looked at the role of point systems for young people. And so we moved away or supported residential partners who moved away from point systems just in general. And that was an interesting challenge for us in New Jersey, since point systems were built into the regulatory work, and by regulation, point systems had to be in place in residential interventions. So sometimes we have to look at the rules and how the rules are written, how they're supported, to make sure that we're moving everyone into best practice. Residential best practices include family-driven care, and that doesn't just mean that parents come to treatment meetings. It means that parents come to all things, right? And that we have a parent voice at the table in our board meetings, that we have young people supporting advisory committees with that for In the world of family driven, we want peer support partners within the residential interventions whenever possible. We want parents talking to parents whenever possible. So we want family choice, parents being able to have the ability to say, no, I don't want that residential, I want this one, but they need to also have all of the information. So getting back to the parent who, it's recommended that the young person has an intensive in-home service and support in place and not a residential intervention. How do you support that parent in understanding why those decisions are being made? In particular, if they see those decisions being made from the perspective of it's about money. We really need to help them understand it's not really about money, because you get the right service at the right time for the right duration, then you're always going to come up with the right budget for that, right? We also want to make sure that we're focusing on family time and bringing in as many family members as possible. Remember, this is a population of young people whose parents sometimes are put in a position where they're very isolated from other family members because of their child's behavior. We want to take that into consideration at every step of the work that we do within the system. Well, from mobile response and stabilization to intensive care coordination, to outpatient care, to intensive outpatient care, where are the other family members and how do we bring them back to this table? And we want to maintain and support those family connections through no matter what happens for this young person. We want them to have those family connections in place. We want our youth to be part of this process, right? From engagement strategies to the individualized planning. If you're sitting at a table in which you're making decisions for young people and they're not there, then you're not doing the work that is necessary. And sometimes it takes time, don't get me wrong. It takes me time for engagement strategies to happen, and you need to actually move and get things moving in a particular direction. I'll give you a quick example of that. When we first started rolling out high fidelity wraparound, we were working with a young woman. She was 16, I think, at the time. And she refused to attend or participate in any of the planning that was happening in the child family team. And the care manager who was regularly scheduled to meet with her and went to her house on a regular basis once asked me, she said, Liz, why do I keep going if she's not going to answer the door? And I said to her, because at some point she's going to answer the door and we need to keep going until she does that. And she did. She answered the door and eventually participated in child family teams, allowed the care manager to help her, implement the plan for her. And so we really just need to understand the importance of persistence in all of this work and engagement. Community strategies and connections are incredibly important, and youth advisory and feedback strategies are important. So in other words, we want young people to tell us how we're doing and whether or not it's working or not. And we want them to tell us that on a regular basis. And we've even moved to a residential best practice in some residential programs in New Jersey where they young people are actually driving the hiring process for the frontline workers in the residential interventions. It's been interesting. They almost always get it right, and they almost always move away from testing a lot of these young people. They don't test the new staff because they are invested in their success. They might.
Just wanted to throw out one more thing as it relates to your language slide from earlier. And maybe just a recommendation. One of the phrases we hear a lot is this youth has no one.
Yes.
And what we know from experience and data is they do. They have people. Mm-hmm. They have people from the past. They have people right now. But when we create that narrative as a system and as agencies, what we're ultimately saying is those people don't have value to us, mm-hmm. or we don't believe they exist. It's one of the two. And so challenging ourselves there. But I think the other important thing as it relates to this slide is when a young person says, I don't have anyone I want to bring to my meetings, or I don't have anyone I want to call, what they're ultimately saying is, I don't feel safe mm-hmm. bringing my people into this process that has historically marginalized my opinions and the opinions of others. So the real question for ourselves is, how do we work a process that helps them feel safe to invite their people into these system processes? So I just want to throw that out.
I think that's a really excellent point and an important point, right? And that's not just true for young people. It is true for young people, but it's also true for parents and caregivers as well. And the way that we have to do that is really by professionals taking the lead from, not leading, right? This is really a challenge for us as professionals. It certainly was a challenge for me to take my, to be guided by young people, right? To have young people drive that planning process, and then to say, who else do we need at this table? Because I'm not the threatening person who's going to say whoever you're bringing to the table isn't going to be important in these conversations. And by the way, when it happens, it's a beautiful thing. We had a young woman in New Jersey who we really believe needed substance use treatment. But we were not pushing the substance use treatment. We were just trying to work on a game plan and help her through. And she brought her boyfriend to the table. And he said, listen, I love you and I want to spend the rest of my life with you, but not until you get into treatment. What a cool thing, right? And we said, we'll do whatever you want, right? We'll help you whenever we want, because we're guided by what our young people say, right? And there's rules around, there's structure around that, right? There's the idea of how do we keep these young people safe in the short term? That's the other challenge, right, in that work. But yeah.
Yeah, thanks for letting me interject. I mean, I think that's exactly right for so many reasons. Who are the people that can come and say the things that the young person would never listen to from us?
That's right.
That's the strength of the network and the strength of the community. And so the last thing I'll say on that before you move on is just that taking your lead from them requires an openness and a willingness to follow that is very, very difficult. I know you said it, but it's harder in practice than you'd think. So
yeah, it is hard in practice, and the only way to make those shifts in practice, right, is to be to test each other, right, to have people who are willing to work through and be thought partners and help get it right. So it's important for us not only to be setting up these communities for our young people and these teams for our young people, it's also important who we put at the table to help us with our own transformation, because this is a transformation process for all of us. There's a question or comment in the box. Engagement is important in residential and intensive outpatient services. Unfortunately, no-shows and contact attempts are not billable. I hope the reimbursement rates are reflective of engagement efforts for behavioral health entities. It's a great comment and important one for folks to take away. It is why we want to build in some upfront work, in particular around care management entities as they roll out. Those care management entities have that need to be able to do the engagement. It's a little bit easier for care management organizations to work within the parameters of those upfront engagement strategies rather than either a residential or an outpatient or intensive outpatient program. In other words, what care management entities and high fidelity wraparound does is it begins to organize around the sequencing of when and how interventions are going to happen. So when care management goes into place, intensive care coordination is in place, even for moderate young people, the no-show rates actually go down pretty dramatically because this sequencing happens, because this planning happens, and because there's a real good coordination around when and how interventions go into place. So it's a great comment and one for considerations for all of you as you move. A few more residential best practices include that trauma-informed environments observe from a self-regulation lens, creating environments that focus on dysregulation, using sensory rooms, weighted blankets, other sensory and sensitive tools, attentive to physical needs of young people, eating, sleeping, moving. I often tell the story of a young person in New Jersey. We called her the $1 million young person. Like she, it was her whole treatment experience was about this $1 million Oreo cookie. We had a program that refused to give her an Oreo cookie. She ended up getting into a power struggle with the staff. She was restrained. She was admitted into an inpatient unit. She was rejected from every residential program in the state of New Jersey. And this is in the early days of the system of care. She was then transported to another out-of-state residential program. She fell out of that residential program, went to others. She cost the state of New Jersey millions in terms of her treatment experience, all because that Oreo cookie set off a chain of events that was really, really about the adults not really knowing how to engage and work with a young person whose stress system was already at max, and just kept going until we actually had to bring her, we actually organized strategies to bring her back to New Jersey, and she eventually was successful in treatment. But creating the idea that we have to look at this from a self-regulation lens, from recognizing that young people are dysregulated, is just important, and more now so more than ever. And not only are young people dysregulated, so are a lot of the folks in the workforce because of their own challenges and stress levels, because of certainly because of the pandemic. We want to shift language and understanding of child behavior and the function of the behavior. We want to understand why young people do some of the things that they do, and move away from the use of diagnoses as a descriptor, right? It doesn't mean that diagnosis is not important or it's not part of the conversation. It is, but we just don't describe young people from the perspective of their diagnoses. In fact, we only use diagnoses to help advance what's going on for that young person, so we can help them understand in more thoughtful terms. I think folks who are listening in who might have been part of this work for a long time recognize that diagnosis isn't necessarily always helpful in understanding what's going on. And many young people move from one diagnosis to another, depending on where they are. And so, you know, recognizing that diagnosis is just one small tool in a very large toolbox is important. Identify the behavior and concern around the behavior in relation to safety, important, and give evidence to the youth's success. We always want to help them, even when those steps are small, understand that they've moved up in those steps, right? That there's some level of success that we should be able to articulate for them and help them. Identify strategies around safety for youth as part of the engagement, right? Right from the start, we're going to talk about young people, about what will help them, even from the grounds of mobile response and stabilization, walking in saying, we're going to do some grounding activities right from the start with young people in mobile response and stabilization, how we're going to use that within the world of intensive care coordination and wraparound planning, how we're going to use those tools within our intensive in-home work, our intensive in community work, our intensive, any of that work we're going to do, right? We're also going to move that all the way through residential. So in other words, for young people to touch on other parts of the system, they're getting the same language and some of the same tools, and they're beginning to learn those tools and how to use those tools across multiple systems. Identify strategies around youth as right from the start. And one of the things we're going to do is build soothing plans that are going to help young people, and we're going to build sensory boxes right from the start. So a toolkit for the young person to use. And by the way, we use not only sensory toolboxes for young people, we had some sensory toolboxes for the staff, right? Things that they can use at their own desk to calm, to be able to work on their own stress levels, all important parts of this work. Another residential best practice looks at the sensory diet, regulation and sensory tools, understanding sight, sound, smell, touch, taste. We want to know where young people are in terms of their ability to balance, be able to feel, be grounded in their own body, if you will. They're balanced in their own body. So we want to use tools such as yoga, chalkboard, weighted blankets, rocking chairs, all of those kind of tools. We also, in residential interventions, we want to make sure that the colors of the walls are impactful, the way the furniture is laid out. So we want to be attentive to all of the details within this work. And then I want to talk really in detail about the role of restraint, seclusion, and coercion. And in this work, I just think it's really important to understand that restraint and seclusion are just treatment failures. They just are. That doesn't mean that the people who are doing that, who are putting their hands on young people, are bad. We're not going to blame the frontline staff for restraint, because in our work in understanding where restraint, seclusion, and coercion fit in the world of residential interventions, what we learned is we could almost go back to the beginning of the young person's touch on the system to see the escalation and where they were going to land in terms of the role of restraint. And so we want to ask really important questions around how young people are prepared for residential intervention, what's their experience on the system, who do we put into place who can help to make sure that those engagement strategies are used, that young people first touch on those residential are really about helping and not about coercion, that they're not, we're not looking for this compliance issue, that we're paying attention to the sensory and dysregulation that young people experience, that we are making sure that their biological needs are met. And what I mean by that, young people don't show up at a residential intervention. Let's start here. They don't show up in handcuffs. They don't show up in restrictive ways. They show up in residential ready to go, right? And that means those who transport them make sure that they're fed, make sure that they're supported, make sure that they've had nurturing time in the car, that that time has been impactful. Maybe they're listening to music that feels good. Maybe they're drawing or coloring. Maybe they're, but that time and attention to the preparation for how young people even touch on that residential intervention right from the start is not insignificant. And the role of leadership in restraint, right, is important. Leadership of an organization. We said that if a young person goes into a residential intervention and they had a heart attack, the CEO of that residential would be on site. We want to make all restraint, any kind of restraint that happens, a cardiac event. I want to be able to call, as the assistant commissioner in New Jersey, I wanted to be able to call the CEO and find out exactly what happened, what they were going to do about it. And what I didn't want to hear was they were going to fire the staff. What I wanted to hear is they were going to work on their own environment, on what led to that restraint happening in the first place. So it's just really important to pay attention to the role of restraint, how young people are restrained, what tools do they use, how is the staff trained up front, how often do they get trained, is there a certification process, is there ongoing conversations, do they look for triggers, how do they bring the community in, and by that, the community, I mean that young person's team, how do they bring them into that conversation? Don't let me be surprised that one of the young people I'm responsible for that you have restrained and I don't know it, that we've not been part of the solution and what we can do to be helpful. All those parts of residential reforms are important to pay attention to. And let me just say this, not a week has gone by over the last, 6 months or so where I haven't read an article about some state that has had young people who are restrained in or treated poorly in residential, psychiatric residential treatment. This is what Kelly and certainly Marisa are worried about. Their attention to the detail of what they want these PRTFs to look like, what the quality of the staff they want them to do. This level of detail is important because what they're demonstrating, which is the most important part of systems transformation, is that the oversight piece of this is important. We're going to partner to make sure young people get what they need in order for us not to have to fall to tools like restraint, seclusion, and coercion.
Could I just add one point to that?
Absolutely.
So what you were talking about was really has a lot to do with culture, with the comparison you were making to a heart attack and how we would respond. Mm-hmm. And one of my favorite residential transformation examples is an organization, a 100-year-old residential in Massachusetts that went on a 7-year journey to transform from traditional to that of a relationship-based model, and their journey of becoming a restraint-free environment included the daily mantra that the most significant crisis that can happen on the floor of our facility is that a child goes a day without connecting with family.
Yes, that's exactly right.
So I just want to throw that out there as a way of operationalizing the kind of
right.
change we're talking about.
And what happens, and you know, that point is incredibly important, because what you read, right, and what you hear about, what you know, because in a lot of these states, we've been, you know, trying to get to these residential reforms, but you're sort of retrofitting, right? What's happening is that there's not been attentiveness around this family piece, right? And to your point earlier, which I think is so important, is that we're not defining the family, right? Young people define their family, right? Young people make those decisions. And so, you know, we may have people who are part of the treatment plan and part of the team that just are, you know, they are important to these young people, but they don't have an actual biological connection to them, right? But we've included them in how they communicate, making sure that they can always reach out to those individuals who can help calm, help be part of. That's why this idea of restraint, seclusion, and coercion is important. And what we know is that when leadership isn't involved and they prioritize it, this issue becomes much smaller, right? Much, much smaller. So yeah, I know about the work in Massachusetts. By the way, there's a program in Virginia that have the same type of mantra for individuals with intellectual and developmental disabilities. And they were successful in moving away from any type of hands-on approach with young people and adults with intellectual and developmental disabilities, because they just said it's about the relationship.
Well, and it sounds like you and I could fill the rest of the time on this topic, so I don't want to go too far down the rabbit hole, but just one more comment on that is that many times from a practice standpoint, when we have a youth that's being restrained and is in seclusion, the thought process or the culture is that this is the wrong time to bring additional people in who may trigger them. And what I would suggest is that the evidence shows from a practice standpoint, it's the perfect time.
That's exactly right.
They're the ones that are going to help us stabilize. So.
That's exactly right. And I just add one more thing, and that is that I took it as a treatment failure as the assistant commissioner in New Jersey. It wasn't just the program or organization that failed. It was all of us that failed that young person. So when I talk about treatment failure, I'm not talking about frontline staff. I'm talking about leadership who is in a position to begin to think and change the culture in which treatment is provided for young people right from the start, right? And setting the conditions in a way that makes sense for folks. A couple of other residential best practices. We're going to look at data and outcomes. We're going to look at length of stay. I already talked a little bit about length of stay. Look, it's not the primary driver, right? It's not the whole thing. It doesn't tell you the whole story. And what I would say is that it has to be very individualized. So we have to look at young people, but it can give you a view for some folks. And so we want to pay attention to it. We definitely want to pay attention to return to care and the time frame in which return to care happens, right? So if it's a short-term return to care, they just transition and they return. That also doesn't tell me the whole story, right? But it tells me some things that I want to pay attention to, not just whether or not the young person did well or it was a good experience, but did we do enough or support enough the transition activities and have enough for that young person to do well. Listen, I've worked with young people in residential. They get very connected to the individuals that are working with them. And so that can be confusing on the return to care, but we pay attention to that. Community connections are really important for us to pay attention to. In the world of high fidelity wraparound, as an example, 70% of the team really should be informal or community connections and not formal supports. We want to pay attention to permanency, and not just our definition of permanency, what our young people see as permanent. We want to look at school performance, attendance, and behavior, juvenile justice involvement, both touch on the system. Can we get young people, out of that juvenile justice involvement? And I'm going to talk about rigorous debrief just for a second, because I think it's incredibly important in this conversation. Changes our whole view of how all of this works, is this understanding of how did we get here in the first place? What happened? And so not only do we want to understand what happened to the young person, we want to know what happened as a result of our own interventions. And what do we do? Did it work? Did it not work? Where were the concerns that popped up? And did we pay close attention to those concerns? And so rigorous debrief is a process in which leadership comes together with all the folks who know and understand what happened in a particular situation, gets all the details around that situation. Let's say it's a restraint that happened. Leadership wants to know that the restraint happened. They want to interview or talk to everyone around that restraint. And they want to take it back and try to figure out, if 2 steps before, if we had done this, if 3 steps before we had done this, what would have made a difference? And then how do we rebuild or plan differently for this young person moving forward? Rigorous debrief should be part of all parts of your work, but particularly important in the world of residential. Okay, so these are my, I'm going to get to any kind of questions that you might have. There's 2 in the box right now, and they're complicated. So it's going to take a minute to work through some of this, and I'm going to need some help from folks from Ohio. I have youth with suspected trauma, and lots of facilities will not admit to their IQ thoughts and thank you. So the answer to that is, boy, that's complicated, right? We don't know why facilities are saying no to a young person. Is it driven death? And maybe, Jeremy, you want to just answer some of these questions in the Q&A for me. Is it because the IQ is identified and because these programs have clear limits around what their IQ is and that they'll accept? Is that the question that's on the table? And do you have facilities in Ohio that specialize with young people who have lower or intellectual disabilities, as well as behavioral health? Is that an area in which the system needs to be thoughtful and begin to think about mapping out and planning? So that's my question for you, Jeremy, if you're still with us. That would be great. In the meantime, I'm going to take the second one, and that is, we have a youth with suspected trauma and a low IQ and no residential provider willing to accept. So this is beginning to sound familiar, right? We have hit a wall after in gaining any type of help to focus her present state. Please advise. Great question, right? So real challenges, and Mike, maybe you can help us problem solve some of this. I don't know. But this is what I would do, okay? So let's start at the beginning. And these were situations that popped up for us a lot in the beginning of our work. And that is, first of all, is there anybody in the community, home and community-based world that can help? Is there anyone providing high fidelity wraparound right now in any of the communities that you're serving? And can we get this young person connected? Why? Because believe it or not, high fidelity wraparound can help prevent young people from moving into residential interventions, even when that has been determined necessary. So that's my first question, right? Second question is, how long have you been looking for residential? Because if we look at residential past this 30-day window, we should be reassessing about whether or not residential is still the right intervention, or whether or not we can put other intensive in-home supports in place. Is IIBHT or IBHT something that could be helpful? Let's see, we have a question here with the changes. Will facilities change the outlook on youth with arson behavior? Will they start taking them? Okay, so I'm a language geek, and so I'm gonna not call that arson behavior. I'm gonna call that fire setting behavior. And that's a real important distinction. And the answer to that question is probably. And the reason that question is so important around fire setting is because there are multiple levels of fire setting behavior, and or actually 3 of the 4 levels are not only well treated, they're very well treated within residential interventions. And so, and the 4th one, we really need assessment to understand what's happened. So my first suggestion to you is, let's not call it arson behavior. Let's say that, let's get some detail on what that means and whether the young person actually meant and had intent to harm. And if they had intent to harm, then that's really what we want to focus our attention on, the intent to harm, because that's a different intervention. And the answer to that question is, I'm going to imagine that psychiatric residential treatment facilities will have some level of expertise in working with young people who have intent to harm, okay? Not just when it comes to fire, but also when it comes to young people who might have demonstrated some sexually inappropriate behavior, might have demonstrated some anger challenges that have been aggressive in their nature. And so those are real specialty populations in which there is real treatment interventions that can be helpful. There's a lot of work that's been done on the world of fire setting, in the world of sexually inappropriate behavior. A lot of these young people can be treated not just in a treatment facility, but to be honest, they can be treated very well in their own homes with the right supports in place. So I hope that answered your question around the fire setting. Mike?
Yeah, I mean, it is difficult to provide sort of a very specific case consultation virtually in this platform, but just a few things from an Ohio lens. So not sure which jurisdiction or part of the state that you're in, but Ohio has, through our Family and Children First Council, some multi-system youth technical assistance and funding available to assist. So that may be something you've tried already, but if you haven't, that would be a definite first step. I think the other question, especially when you have this sort of crisis around placement, is that recognizing that's a system need, and to your point around what are we solving for? What does this child need right now can also help to change that perspective. And so asking who loves this child, who cares about this child, who's willing to come to the table and think a little bit more holistically outside of the placement crisis. What does this child need in order to live a good life and to be healthy and to process and heal? Those are different questions that are difficult to ask sometimes in the moment of crisis. So I fully appreciate what I'm suggesting, but I think it's an alternative approach to the harsh reality. You are not alone. What I will say from an Ohio perspective, we recognize that there are youth with very complex needs, and we are all seeking placements across our state that simply don't exist right now. There is an alignment and a capacity issue. So you are not alone, which is really also an opportunity for us to think differently and practice differently. So again, hard to give more specifics this way, but hopefully that helps some different thinking.
Yeah, I agree. It's really hard to, because I don't know exactly the resources and the tools you have in your tool belt. I'm just going to talk broadly about some of the considerations for residential redesign when it comes to children with intellectual and developmental disabilities. As I think I've said, I ran that system too, both, not just for children who had co-occurring. And the considerations are a couple that are really important. Number one is many, if not most, a very small percentage of young people really need a residential intervention because of the intellectual disability, right? And sometimes really large behaviors and seem really worrisome behaviors can be managed well with a right plan for young people in their own home. So as you think about building a system that's going to meet the needs of youth across these silos, it's important to know that you want to cross silos on interventions, right? So as an example, for a young person, I might want to think about high fidelity wraparound that includes some intellectual and developmental specific approaches like positive behavioral supports or applied behavioral analysis. I want to have some individual support, so some work around skill development for that young person. We might need to have some communication tools that are important, not always for the young person during the day, but in crisis, they begin to, when we experience a crisis situation, and this happens for most people, if not all, they begin to lose the ability to communicate, and communication becomes more complicated and words become harder to hold on to. This is even more dramatic for young people who have an intellectual or developmental disability. And so the communication mechanism in which they communicate when they're doing well isn't the same, right? And so understanding how they communicate when they're not doing well becomes the primary goal, right, for the team, and trying to figure out how do we support this young person when they're beginning to escalate. and things feel like they're really out of hand. So a couple of things that are important. Okay. Okay, so it seems like that the populations that folks need to really begin to think about, as we think about them as specialty populations, right? Young people who have demonstrated fire setting behavior, we didn't talk about, but I'll add young people who demonstrated sexually inappropriate behavior, aggressive, highly traumatized, challenges with IQ, are this specialty population who require some real expertise sitting around the table. But that expertise is around twofold. And I just put this out there for folks to think about. As you're reorganizing your system, you don't want just folks who have this experience in intellectual and developmental disabilities sitting at the table. You want people who understand how systems work, operate, so that they can suggest and put on the table things like in-home services and supports, and how we can make those in-home services and supports and adapt them for young people who might be demonstrating some more aggressive type behavior. So I just, when you think about systems design, it's just important to take into consideration of these particular challenges and how you're going to make these things work a little bit more smoothly. Kelly, if you're still with us, if you could, I don't know what your thoughts are in particular around this challenge for young people, both with a lower IQ and this issue of young people who are fire setting. Do you have any thoughts about that?
Young children with lower IQ and what?
Who have demonstrated fire setting behavior?
I think we are trying to make sure that we are building capacity for those kinds of PRTFs around the state, but still allowing for flexibility for PRTFs to set admission criteria. But we are working with Aetna to make sure that they're contracting to make sure that those children are served around the state.
Yeah. Listen, I'm just going to add one component for you. It's funny. This question comes up for me a lot in other states, and I ran the state for 5 years. This was never an issue for me in the 5 years I was there, where I couldn't find a bed for a young person who we were worried about the fire setting behavior. So, and I think it's because of the way that we design the system, right? To recognize, first of all, what fire setting is, what it does, and to think about it more in this idea of dangerousness, right? Or intention to harm is the way to think about it. That the young people who didn't have intention to harm, who set fires, that those young people actually, your general mental health practices, in treatment interventions will actually work. That the care plan for high fidelity wraparound is going to work for those young people, whether that's an in-home or a residential intervention. But this, and that's why I would separate it out, and I would separate out the intentionality to harm, because that requires a different intervention, and some psychiatric residential treatment providers will hopefully have some ideas and thoughts about how to provide intervention that makes sense for them.
Yeah, and this might be also an area for the COE to do more training, and I know that we talked about that in some of our work groups earlier on. Yeah, providing some of those kinds of different types of training opportunities that exist, and we know that there's a gap in providing care for these different needs.
Yeah, I think the training is important, right? Because people get a little freaked out by this idea that a child set fire, and the fire might have been big, right? But their intention around the fire was small. They didn't mean it. They were playing with matches. They were just curious. They were, or they were upset. They were upset about, something happened. So some trauma comes into that. But they didn't have intentionality around the harm. And that's where the assessment process is so important. There's been a lot of research around fire setting, so it's not new. It's not a new area of, in fact, most of the fire setting research is actually quite dated at this moment, because we found a lot of solutions that work for young people. And I'll just give you an example. When I was running the PRTF world back in the 90s, we were trained in fire setting. You know, I went through this training, and we had an exclusionary criteria that said, we don't take anyone who set fires, but we didn't specifically ask the question. So I was working with 6 young people. I went back and I asked the question, 6 out of 6 had set fires, but none of them had set fires with intentionality, right? None of them wanted to harm, right? They didn't want to harm, but they were, you know, they were curious, but all of them would have been excluded from admission into the program if we'd asked the question. And that's why I asked this question for you in terms of, what do you know about it? What do you know about the treatment? Do you have good assessors who can tell you what that fire setting means? They can look at, and there are good assessment tools that are get embedded in the cans, right? They're not embedded, but they're triggered by the cans that says, okay, we need more information about this fire setting behavior. So we need to bring in somebody who can help us with that. So those are the things to think about in systems design. In terms of the young people with IDD, in particular low IQ, I would ask a lot of questions on why. What is the exclusionary criteria? Most young people who have an intellectual disability or a low IQ, you know, they do well in the same treatment interventions. They just move a little slower sometimes. So. Okay, so let me just make sure that we've answered all of these questions and see if there's any. Okay, we have someone who says, speaking from the perspective of a former counselor in a residential treatment center, I think the goals of no reject, no eject, 0 restraints, no seclusion, and no points are well and good, but I'm worried with ever increasing more aggressive youth to serve, we aren't giving providers other tools to keep youth and staff safe. At the end of the day, when one youth is seriously injuring another, what do you suggest? I think that we need more real world boots on the ground strategies, not just 10,000 foot philosophy. If we are really going to impact change, sorry, rant over. Hey, listen, I get it. I understand what you're saying, right? And I would think the same thing, but there's a couple things you should know. Number one, I used to believe that too. And I ran residential for 15 years. And then I didn't believe it anymore because we got more tools, right? We built tools into the work that we did. We learned, we became a learning environment. We did our research, we talked to other people. And there are a lot of strategies to move away from restraint, seclusion, and coercion. There are a lot of them. I will also tell you this story. In 2015, we introduced those tools in New Jersey and said we were setting this lofty goal of moving away from restraint, seclusion, and coercion. And I had the CEO of a residential program raise her hand and say, it all sounds really good, but we're no eject, no reject, no eject. And the kids they require restraints. And I said, I haven't given you any tools. And so once I give you some tools and we practice these tools and we do what we need to do, give me feedback and we'll see if they're the right tools. And if they're not the right tools, then we'll try different tools. She was one of the first pilots within that program, and within 6 months had moved away from the use of, moved away from point systems. There's still some restraints that were happening, but we could track them and figure out what was going on and increase the level of community engagement strategies for young people. There are strategies to move away from restraint, seclusion, and coercion. And I was a former counselor in a residential program and the former director in a residential program. And I know that I moved away from and got to 0 restraints in the program that I ran. We have been no eject, no reject in New Jersey for almost 20 years. So I think that if we can do that, you can do it too. I think it really is about building these skills into the work that you're doing. And the role of the Center for Excellence is not insignificant. The role of these tools that we've been talking about all day are important for you. And I'm happy to talk more about it with you. I'm happy to help, point you in the right direction of how that's working. I don't just you know, I'm not just saying these things. I actually work with residential programs. I even consult to a residential program that's hands-off these days. So these things can happen. And I just want to point out a couple of resources for you to take a look at right up front. This book right here by Beth Caldwell, Gary Blau, Residential Interventions for Children and Adolescents and Families is important. It has a lot of best practices. There's an updated version of that book. It's called Transforming Residential Interventions. All really, really helpful ideas around how to do it. And the last thing I'm going to say about this, I never said that this was easy. I never said it was easy. I just said you have to be persistent in it and you have to work together in it. And you have to work in moving in the direction of bringing these best practice tools together, right? Elevating youth voice, elevating parent voice, connecting to the community, all important strategies. You also need to think about, right? Making sure that leadership is engaged and part of the conversation. You want to study your data, understand the data, and you want to understand the best practices. So those are my comments on how do you get there, right? These are the strategies to get there for sure. Are there any other questions? Oh, let's see. Okay, there's a good question around if we allow for no redirect up front, how do we guard against no reject, right? And the answer to that is really oversight and working with providers around when they want to, you know, really, I'm just going to say it, kick kids out because of what young people have done. So the answer to that is setting up scenarios in which if young people's needs are not being met in a particular residential program, then what do we need to do in order to meet their needs? That means more teaming, bringing teams together to really problem solve that. That means we bring the high fidelity RAP team right into the residential, talk about what is necessary. Do we need more community engagement? What do we need in order to meet the needs of this young person? More often than not, a lot of these young people actually transition back home with intensive services in place because what we realize is that residential intervention probably wasn't the right step for them in the first place. But in my time, not a lot. We haven't had a lot of programs that said, we just can't manage this. This is, you know, you're asking us to do too much. Okay, we have one more. Comment is, thanks so much. Your response, totally agree that training component and the role of the CEO, the Center for Excellence is huge. There's no doubt about it. One more comment. Let's see. In my experience, if the issues and trauma of the parents and caregivers and or siblings are not addressed, then the outcomes for the identified child will not be successful. Any thoughts, especially on how to incorporate services and supports for the whole family into the parameters of the new treatment approach? That is one excellent point, right? We don't just take care of young people, right, who are, in our view, we take care of the whole family. A couple of strategies that we have used around helping parents who've experienced that same level of trauma and siblings. Number one, let's just first of all recognize that peer support is a really helpful tool in engagement of parents, and peer support for parents begins the process to think about what can we do, what will be helpful. In other words, as a clinician, I don't want to tell the parent what they need to do, but I let other parents work with parents, right? Other parents talking to and helping can help sort of create the space in which we can figure out what the next step is. And also, we want to recognize that the first precursor to healing is that creating that trauma-informed environment, right? It's the environment itself. So when we go in and help young people in their own homes, even if they're in a residential intervention, we want to do this work. We want to create space within the house, right? In which healing can begin to happen, and community connections in which the healing can happen. And then if there's formal supports that are necessary, how do we connect that parent to formal supports is a different story, right? But we use the same tools that we use for young people. And by the way, we're going to do that for siblings as well, right? We're going to connect the dots for siblings, whether that's in some support groups or whether that's in their own intentional community engagement strategies, whether that's engagement in some therapeutic interventions. We're going to look at all of that, not just one part of the family. Mike.
So I agree with all the points that you just made about the whole family approach. The thing that I would add that is often one of the most difficult steps and often skipped steps is co-creating a definition of success and wellness for that full family. Many times the interventions are focused on, as you've mentioned over the last few minutes, fire setting, behaviors, right? These are our goals for the child. Mm-hmm. And those are good goals. We need to address those things. But if we're looking at it from a whole family perspective, how would that collective family, how do we bring them together and ask them to go through a process of defining what success and wellness and health looks like for them, and then allowing them to design what some of the steps are to reach those goals, versus oftentimes we find ourselves, especially in these complex dynamics, trying to mediate conflict mm-hmm. while also working treatment, while also dealing with family dynamics. And so we can't accomplish all of those things in a very spoke and hub manner, right? We will exhaust ourselves. So how do we bring everyone together and define success collectively, and then allow that family to work a process towards health?
Yeah, that's a great point. And the way that starts really is in the family's definition, right? The family vision, as we would call it in high fidelity wraparound. What does the family believe? What does the parent believe? What do they want to achieve? And I'll give you two of my favorites from my work in the high fidelity wrap world that translated into what happened for young people in residential. And that is one parent and caregiver said, I want to see my child smile again. And brought me a picture, right? Not me, but brought the team a picture of the young person smiling. And that picture sat on the table when we were doing the child family team meetings. And so that young person saw that picture of them when they were smiling. We worked hard to try and figure out what got in the way of that happening. And the other parent, who just was a great story, would say, I want to go on vacation and I want my child to be able to be on a plane and be able to for us to have a successful vacation. And so we actually did drawings, right? Pictures of what that vacation would look like, and for the young person to understand what their parent was asking for. So the family vision is very important, but let's not forget that the young person's vision for themselves is equally as important. And so we want to not just have the parent's vision, we want to have that child's vision, and they should be part of the treatment plan. It should be part of what actually gets reviewed on a regular basis. How close are we to getting to that place where you can be on vacation together? Like, what will that look like? Okay, a couple more comments or questions that I just want to touch on. Let's see, can you make a comment on how You Thrive framework could help as people are looking at ways to build their toolbox, especially in terms of areas of target will help? Listen, You Thrive has a model, right? It has a lot of tools in the tool belt. So for folks who are not familiar with You Thrive, we'll get you some tools. I'll include, you'll have this presentation. I'm going to add some more tools around You Thrive because it's really important. And we did use a lot of the ideas of You Thrive. Some of the work, the residential reforms in New Jersey actually started pre You Thrive work, but we've coordinated some of that work around what's happening. So if you're not familiar, I'm going to add some tools in there for you. And the other toolbox place you want to look at is Building Bridges. And the Building Bridges initiative has a lot of resources for folks, including the step-by-step, how did organizations move away from point systems, right? How did they focus on relation-based interventions? And there's a lot of work that's been done both through You Thrive and through Building Bridges to help states think about this work and providers be able to implement the work as well. So really great point, thank you. And then let's see, we have a comment about how the philosophy not only does not traumatize the children, but also staff implementing the restraint. That's true. It attributes to our survival skills and caretaking and become so traumatic for the caregiver and the child. That's true. And let me just give you a quick story from New Jersey. We set the goals, like we wanted to move away from restraint, seclusion, and coercion in residential treatment programs. And what we did to do that, so you know we were intentional, is we brought in and did training on the 6 core strategies, which is an evidence-based practice to move away from restraint, seclusion, and coercion. And we built training. We did a lot of training on the nurtured heart approach, which is really, from my perspective, how we bring language and help people communicate together, right? And we brought those 2 strategies to New Jersey, and we trained every residential program in New Jersey in both of those strategies. And then we gave every single one of those programs had a coach, and the coach stayed with them for well over 9 months and just implemented all of these tools around it. And we built what we call super user groups in New Jersey. Other people might call them communities of practice, where they came together and talked about, they would have one person from each of those facilities come together and talk about what worked, what didn't work, you know, where are challenges, how do we do this a little different? So this idea of bringing people together. We also gave all those residential partners the book, Transforming Residential. So we did a lot of these kind of things to help people begin to think different. One of the side effects of that, not only did they see restraint come down, they did, and they moved away from point systems without, before timeframes were even, before we even had a chance to get to timeframes. They just found them not useful. And then one of the side effects, or one of the things they didn't expect, is that their call out rates went down in every residential program. So staff were coming to work more frequently, and their turnover started to decrease pretty dramatically. And so because staff were happier about being there. And one of my favorite things about the Nurture Heart approach is that the staff members in the state who were parents started using the Nurture Heart with their approach with their own children, and started to come to work in a better place because they had more success with their own children. They weren't in power struggles all the time. So, you know, the thoughtfulness around the training piece is not insignificant, and how we begin to think about frontline workers in residential being trained, but they should consistently be trained. What I didn't say is that not only did the residentials get that training, so did all of the care management organizations, the mobile response teams, the family support organizations. So there was consistency across the system in the language and the expectations of finding young people's greatness. So I think I got to all the questions, unless there's any more. Oh, yes, here's one more question. Here we go. Do you have examples of what kind of things you should include in the sensory boxes for youth and staff? Yes, I do. I have a slide on it, which I wasn't in this presentation. I'll add it to, and it's just a lot of things. One of the things for mobile response teams, as an example, I would want to have paper journal. I would want to have a jump rope, something that they can move around. I would have some kind of fidget toys in my box, but we can work with young people themselves on trying to figure out what should be in their sensory boxes. Okay, somebody wants me to show the thank you slide. There you go. There you go, just for you. Here's my thank you slide. Okay, and there's my email slide. So if you have any questions, any other challenges, you think I'm wrong about something, please feel free to reach out. I'm happy to answer any questions, talk through any of these challenges that you might have. I know that this work isn't easy. It's really, really complicated and hard. I can just tell you that it's every single thing that you're doing is worth it if you're moving to improve the life of children and families. So I thank you for your time. It's been an honor and a privilege to join you, and I hopefully be a thought partner as you work through your transformation.
Thanks, Liz. We really appreciate your inspirational stories and experience this morning. You really shared a lot of helpful and inspiring, thinking about systems transformation and what we're doing in Ohio and how we may learn from other parts of the country. But I think one of the things that I found most helpful from you this morning is breaking down some of the complex acronyms and language. We throw a lot of those around, and I think that was really helpful to hopefully give some of the folks on the call some basic starting points for where to work with. And also thank you to Mike and Kelly and Marisa for providing some Ohio perspective on some of this. And thank you to all of you participants. I hope you found it very inspirational. We have so much work going on in Ohio, and we are going to accomplish so much in the coming years. Appreciate your patience with us at the state, as sometimes things take longer than we hope that they will take. But keep the faith, doing what you do every day in the meantime while we work on a transition plan. And we really look forward to seeing everything that our communities can do in the coming years to improve the lives of children, youth, and families. Sherry?
Thanks, Lois. Again, I want to thank all our speakers too, Elizabeth, Mike, Marisa, and Kelly, for the great presentation. We got so many questions and good feedback. I really want to thank our sponsors too, both Alicia and Lois and the Department of Mental Health and Addiction Services. We also want to thank the Great Lake Mental Health Technology Transfer Center. The links to the GIPRA and the SurveyMonkey are in the chat. You will also receive these in an email later today. Please make sure you complete these, particularly if you're looking for continuing education units. You will need to complete these. And then once you have completed them, you should receive your continuing education credits in the next couple of weeks. So with that, it's been a great day. I hope you all have a great rest of your Friday and a happy Thanksgiving. Thank you so much for attending the Crisis Academy. Bye-bye.